So a very good morning, a very warm welcome to everyone who's joined us today. Sadly not online because we were able to establish visas which will take place for 2 months. And I apologise for any inconvenience. Can I just say a huge welcome to two new colleagues to the board. Juliet Cosgrove, Interim Deputy Chief Nurse, very warm welcome to you, Juliet. And also to the Goodwoods, who's going to be taking over Margaret Jamie as Trust Secretary and I know that Sean is in the room, he's going to be speaking to us shortly about the experience and short contribution soon. Just want to make sure that everyone is. Can you hear me clearly? Yes, you can. It's definitely seeing me. But can I move then straight away to the Faith Experience story and invite John to take us through that?
Everyone hear me through there? Is that right? Okay, yeah, okay. Morning, everyone. My name's John, and I work in the patient experience team. Sadly, the nursing team involved in this story today weren't able to join us for the meeting, so I'll be presenting the story on behalf of the cardio rehab service Salford. Today, our patient is Kay. Kay lives with her partner and beloved pet dogs in Pendlebury, Salford. Kay works part-time locally and likes to spend her free time with her family, watching cricket and Manchester United. Kay had been experiencing chest pain on and off for a while, but assumed that it was indigestion or something minor and didn't think too much of it. One morning, Kay remembers waking up not feeling quite right, but couldn't put a finger on what the problem was. Kay's day continued as normal, and she hoped that the feeling would pass. As the day went on, Kay mentioned to her partner that she was having pains and a loss of feeling in her arm, but thought she just needed to lie down. A few hours later, after not feeling any better, Kay decided that it was time to get some help, and she asked for her partner to call for an ambulance. Kay recalled that she had a blood pressure of 248/104 and was taken to Salford Royal. Kay arrived at the emergency department and waited for triage. During this time, her condition worsened. After some more tests, Kay was told that she'd had a right-sided brainstem stroke, and a swallow test was carried out, which she was unable to do. Kay and her family were shocked to hear that she had a stroke, as there was no family history, and Kay's first thought was, what happens now? Soon after, Kay was admitted to B4, where an NG tube was fitted so that Kay could have some food and fluids. Kay remembers moving onto the ward felt scary, as there were some really poorly people there, and it gave me a realisation that I was quite unwell. Sadly, people around me were dying, and this gave me and my family a fright. After this, Kay went on to stroke rehab unit for 10 days. Here, Kay had regular sessions with the physio and occupational therapy teams. Whilst Kay describes her time on stroke rehab as positive, she suggests that there could be more thought for patients' mental health and well-being. Kay adds, whilst I was physically being looked after, I think my mental health could have been considered a bit more, as I may have been physically getting better, but I was struggling to come to terms with my condition and what the future might be like now. Kay describes that at times on the ward, she was feeling low and struggling to motivate herself to engage with the physio and rehab sessions. After a few days, Kay was ready to be discharged home. This felt worrying as her partner had mobility issues and they were understandably worried about Kay's care once at home. Kay was soon visited by a member of the community stroke team and then by occupational therapy. Occupational therapy Michelle Cross visited Kay at home, and Kay describes Michelle as fantastic. Kay recalls how Michelle helped greatly with her mental health and physiotherapy and gave perspective on what had happened and what the future could be like. Michelle helped with getting back to normal with tasks such as shopping and housework, but most of all provided someone to talk to about what she had gone through. Kay adds that this was just as valuable as any physical care I had had in the hospital. Unfortunately, Kay returned to hospital 3 weeks later and was admitted to EAU feeling very unwell. More tests followed, and Kay was told that she had angina. It was here that the cardiologist suggested that Kay would be a good candidate for the Salford Cardiovascular Rehabilitation Programme. At first, Kay thought, not a chance am I doing that. And it was only after another hospital admission due to angina that the realisation hit for Kay that they needed to be a positive change. It was now that Kay thought, what could go wrong? Kay attended the first appointment with her partner and met Susan Casnello, a cardiovascular rehabilitation specialist nurse. Kay describes feeling nervous, anxious and completely out of her comfort zone. However, Kay needn't have worried as she instantly felt comfortable with Susan and the team. Susan adds that the first session is where the individual is assessed as a whole person, not just by their condition. Susan goes on to say, it's not always about exercise, it's about everything that goes with it. What are the individual's capabilities and what kind of rehab will suit them? Kay recalls that Susan had to ask some personal questions to get to know her better. Even though these questions were private, Kay felt comfortable and safe to talk about her personal life. And Kay spoke honestly and openly about the habits and lifestyle choices that may have contributed to her condition and felt confident when discussing how to tackle them. Susan told Kay that the support that the service can offer, which includes exercise, psychological support, understanding of the diagnosis and condition, guidance on diet, medications, and also identifying what really matters to the individual during their rehab journey. Susan quotes, we focus on small things, achievable goals, and take it one step at a time. Our service is a whole team approach. Susan asked Kay during their first session, what are your main goals and what do you want to achieve from this programme? Kay responded, to get back to being me, to go back to work, to lose some weight and to do everyday things that have been taken away from me and to not continue to worry about what might happen. After lots of discussion about what Kay wanted to achieve, it was now time to do some, albeit gentle, exercise. With the help of the physiotherapist, Isabel, Kay used the treadmill and exercise bike. Kay described the feeling after her first session. I felt knackered, but full of energy. This wasn't what Kay had expected, but she was happy that she had started her rehab journey. Kay started to look forward to her sessions and the new sense of achievement she got from being active and described that every session felt like a weight was being lifted off my shoulders. Kay had a meeting with the dietitian where changes to food and diet were explained properly and the positive effects that this could have on Kay. Kay describes feeling part of these conversations and not feeling pressured or forced, but given the knowledge and information to make informed choices. They do push you, Kay says, but in a good way. Only you can make these positive changes. Kay learned that the best way was to not take on everything all at once. Rehab is a journey and things can feel overwhelming if you take on too much too soon. After regular contact with the cardiovascular team and now armed with the new tools, knowledge and capability, Kay felt ready to be discharged from the service. Kay said that this felt like a good achievement and she was ready. She was also offered a reduced membership at her local gym as an incentive to keep active. Kay felt motivated with a new mindset, positive outlook and positive outlook on the future and improved mental health. During her rehabilitation sessions, Kay had been given the awareness and empowerment to change some of her previous habits and had significantly reduced her smoking and alcohol intake, along with losing a considerable amount of weight. She started a phased return to work, which quickly increased as she felt better and more able than ever before. Kay has also made some significant changes to her routine, such as longer, more fulfilling walks with her beloved dogs, healthier meal choices and planning holidays, all of which she had never imagined was possible before her experience with the cardiovascular rehab service. Kay hopes that by sharing her story, she will motivate others in a similar situation to accept the help, support and guidance of the service and encourages people to not feel scared. Kay states that the service is there for a reason and the positives outweigh any negatives that new patients may be feeling. Kay comments, it's different for each person, but it helps with so many aspects of your life and puts you back on track. Kay describes herself as feeling invigorated about how far she's come and she feels like she's got her life back and more. I care about things more now. I've been given a second chance. This feels like the beginning and not the end.
Thank you very much, Donna, for an excellent presentation, especially when it came to such short notice. Really grateful.
No problem, thank you.
But also a thank you to your colleague, Susan Casnello, cardiovascular rehabilitation specialist nurse, who put this together. And of course, most importantly, thank you to Kay for having the courage to share her experience. And she's taken us through a number of different levels of that experience, from her anxiety to her engagement, her realisation with her own illness, her acceptance of that illness through a whole range of different levels of, again, interaction with colleagues, particularly our allied healthcare professionals. We don't talk about them enough. We talk about our doctors, we talk about our nurses, but our specialists, occupational therapy, physiotherapy, stroke rehabilitation, it's very, very important. What really resonates with me, and I'm sure it resonates with colleagues, is that when one is ill, it isn't just about the physicality and the clinical components of that illness. It is about our psychology and how we address what's happened to us. In terms of that, understanding the impact of that not only on ourselves but on other people, and also begin to appreciate what we can do differently in our life. And Kate has addressed all of those components in this short narrative, and she's highlighted that, I'm sure to everyone, that our values, care, appreciate, inspire, are completely co-located with each other in this very important narrative. So much to take forward, much learning to engage with and embed within our own thinking, not just as board colleagues, but also across the footprint. So can I thank you again for coming and presenting, and please pass on my kind regards and that of awards to one of our colleagues who played an instrumental part, and of course, if you can, to Kate.
I certainly will do. Thank you very much. Thank you.
Thank you.
So the next item on the agenda is apologies for absence, but actually, before I go to agenda item 3, I'd just like to take a moment to reflect on this wonderful colleague, lady, who's survived outside David Burns. Now, this is quite difficult for me. I'm coming quite overwhelmed with it because I've only known you just 3 years. But I've learned so much from your incredible mind and the way that you think, and most of all, how you engage with people, how you show you care, how you demonstrate empathy, compassion, all those aspects I've just spoken to in the previous paper around care, appreciate, inspire. You are walking, talking evidence of how that should work in reality, not just in the workplace, but outside of the workplace. You're reaching hands, and I know that you are the governance guru, the risk management guru, but aside from that, you are the people person. And you have been with this organisation for plus 20 years. Been fabulous. We all know much longer. And even though, as I said, I've only known you for a little bit of time, those who worked with you throughout that time and those who worked with you at left the organisation still remember you. The fact that we think about our legacy and how we spend our time, the most important indicator of how well it is spent is how people think about us when we are gone. And I'm pretty sure that everybody will hear Jane Bowes, you're popping to her head like a finally being gracious, being very, right word, dignified and delicate, but at the same time, a powerful punch when we need it. Really a great reminder to say, we're off track with that, Ravina, we're off track with this, we need to get back on track because you have that insight, but you do so in such a constructive way. It's a gift to be constructive when you're giving feedback. And it's a gift to understand people and come down to their level. So you have a conversation in which they feel valued, although you may be telling them directly, but that's okay because we appreciate that sometimes these things need to happen. So in my comfy kind of way, I'm trying to demonstrate to you how much you are loved, how much we care for you, how much we appreciate you. And there will be a board dinner soon to celebrate some other aspects of your life. But for now, as we pause to go on to the main agenda item, thank you so much, Jane, for everything that you do and what I'm sure you'll continue to do. We will miss you tremendously. There will be an empty space and we'll be looking for you. But we know in our heart of hearts, in all the 4 things we need to go forward, and the progress that we make, there'll be a little of Jane saying, good job. Always a minute pause, reflect, and let's think of how we can do these things differently. So thank you. I'm pretty sure if you work with council governors and all our governor colleagues will say something very listening. Very much indeed. Okay, back to the main agenda, colleagues. Apology for absence received from Professor Heather Caudle. And that's why we have Juliet with us this morning to present. Rachel Jones, non-executive director. I think that's the only information I have received. Is that correct?
Laura Murray.
Oh, Sue Rowland. Yes, Sue Rowland, of course. Thank you very much for that. Can we move on to agenda item 5 minutes of the previous meeting? May I receive confirmation or otherwise from board members that the drafted minutes from the board's previous meeting on the 8th of January can be approved as a true record of that meeting? Colleague, I'm looking to you then.
It can.
Thank you. Agenda item 7 is the action track. No, it's not. It's agenda item 6. Matters arising from the previous. They're set out there for you to observe. Are there any other matters not listed which will board members have to bring to my attention? That a yes or a no? Do you now move on to the action tracker? The action tracker is provided for review. Are there any questions or comments that colleagues would like to make? Are you content with the way and the manner in which the information is presented on the action? So, yes.
Excuse me, I think there is just one from. Thank you.
Thank you, Chair. On the matter of striding, we've had some questions in the past about SHIMI data, which has come out of our learning from deaths report. I just wanted to update that there are 2 things happening in that space. One of them is, if you recall, we had up to do a little bit of analysis related to health inequalities and mortality, which the team has done. And it's a very interesting analysis. The health inequalities data, some ethnicity data, is very light on the ground, and not all of it is incorporated into SHIMI. But the team are essentially changing some of the detailed analysis that they will do on the back of SHIMI, because what they're realizing is SHIMI sometimes underestimates mortalities and doesn't have the nuances for specific specialties. So some really good work happening there just to develop how we're going to look at mortality in a little bit more depth. And the second thing is we have been in touch with Professor Mohammed Bradford University, specifically around some additional insight and training into mortality statistics and how we analyze them. And we're in the process of just agreeing a date for that to happen with the whole team, and we'll schedule that.
Thank you very much. That needs to be 5 minutes, not. Can I just make a note that with the action tracker, 8 actions have been transferred to QPC, 4 to our people and education committee. I just wanted to note that because it did demonstrate the amount of work that's going on. But with the transfer arrangements, there's no indication of whether the work is in progress or in situ. Can anybody comment on that?
So, right here.
So in the action tracker, I did notice that there are quite a number of items which have been transferred to QPC for onward in-depth discussion and oversight and scrutiny. And I'm just wondering, there isn't a kind of within the completion confirmed board, there's no date that just says it's been transferred. I just wonder whether there are insights into those particular.
I've not listened. What did the press say?
Right.
That means yeah, I think we've been actually when I've read those, it struck me that many of the things which are transferred are actually almost business as usual for the committee, in the sense that some of the issues that come up from learning from deaths or from the instance or elsewhere are the sorts of things which, you know, in a fully functioning system, we would receive through escalate by escalation from repeat and sort of considering that way. So I think we could say that they are already part of the committee's work programme in a regular way. But I think what we'll do is we'll just make sure at the next meeting that we've covered everything and we've looked at the specific. There's some specifics in there on that are picked up. That
I suppose, thank you, Chris. I suppose my observation really is that when we are when these are papers are open to the public, it's just to help and enable them to understand that they absolutely are transferred because
Yeah.
it falls within the remit of the Quality Performance Committee or the People in Education. And I'll come to you again, Aziz, but it's just making sure that we are on track with those mistakes and scrutiny.
There is a bit of work to do to make sure that the cycles of reporting fit with each other. And for example, we've had, today we've got 2 reports from QPC on the agenda. So it's just a bit of something about making sure those work programs are in track with each other, and so that at QPC we're looking at those issues after they've been delegated to us, as it were, so that we can respond.
Yeah, that's great.
Makes sense.
Thank you very much, Chris. Aziz.
Thank you, Chair. I think it's a good question, what happens to them. I mean, I trust that they're transferred to People Committee and they come to us. And some of these I know have come to us. And on the right-hand side, it does say completion confirmed to board, i.e. to us. And I know a couple of those that are transferred to People Committee that we've done, and I recognise that I remember them. The others, I can't remember everything. But so it seems to me that that process is working. However, I don't personally track everything that comes from this that says it's transferred and then it comes to People Committee. But looking at this and the subjects, I recognise them. I remember discussing them, and it said completion confirmed to board here on the right hand side in January for a couple, and I know they were discussed by us in the past. So it feels to me like that's a system that's working, but I don't personally track every single one.
Thank you very much.
So I made a note when I was preparing for the meeting that one of the items which is says transfer to People and Education from the R&I committee, which was about the impact of recruitment and retention of clinical coders. Because I'm on both those committees, I felt as if, yes, we may have transferred it, but I'm not sure it's been picked up in the People and Education committee, because I don't think the visibility of the transfer is there, which is back to your question. And I know that Gertie and her team are looking at that with Lorna's team, because we've had the discussion, but I'm not sure we note it in the P&E committee, and unless I've missed it, because I went back to the previous notes and thought, I can't remember picking up the governance piece that says we've transferred this and we are dealing with it. So we are dealing with it, but I'm not sure we've noted that it's been transferred.
Thank you. That's really good. Really frustrating. What further we need to do, it's so the alignment of what we see and what we list, because I generally feel that the board papers are greatly improved. Actually, greatly improved. We just need to continue to strengthen our governance, our oversight, and health insurance, and that's of course, as we are a unitary board, for both the non-executives and the executive director. But there's also a leadership role that the executive directors have to fulfill in that context. Well, thank you. That was a really helpful. Sure. Oh, Jude. Good. Oh, okay.
Just to confirm, the process we follow is that if we're putting transfer onto the action tracker at board, that action as it stands is transferred into the action tracker for People Education, for R&I, and so Aziz, I completely support that. You can't track personally every one of these, but you are tracking them because you are chairing the committee worthy, and I know that action tracker is rigorously reviewed. Carmen, I know your comments though, and that does make me just want to say to the team, can we just be triple checking that we know those, and I hand on heart believe we are, but we will do that. Just a quick sharp audit just to double check that those actions are transferring. Thank you. But that's a process that we've had for some time. Thank you, Chair.
Yeah, I just want to move us away from the process for a minute and just the substance of some of the issues, particularly around line of sight, the Board for Adult Social Care Metrics, which is described here. It has been transferred to QPC. I actually don't think it's a QPC issue either. It's as much a monetary issue. So I do think it is about board oversight of adult social care in the same way that we've had that conversation about line of sight to community services and the performance of community services. I'm not going to look at Jack when I say those two things. So it is a wicked problem because it is about getting data out of systems for Lorna's teams, which is not easy to do. Tim helpfully has shared with me some of the adult social care reports from Manchester LCO that give them line of sight. But just to manage expectations, I think Tim said to me it took them 2 years to get to a position where they could see things visibly. So what I think we will commit to doing is working on the performance scorecard as we set it for the 25-26 plan, is looking at what we can get readily and easily and start to pick out some key metrics. And I'll agree that, as we do every year in this conversation with the next, about what do we want to see in the board scorecard, but I'm not sure it will be a quick fix, if I'm honest.
Thank you for that further clarification. Adult social care is one of those which is challenging because we don't have access to give ourselves insurance. So there's a missing link there. The more that we do aim to recognise that and acknowledge the challenge within it, but also the opportunity to address it by saying what can we put through the key metrics and follow and track in order to give that assurance that we so for this board. So that's a very helpful discussion with Colin. Thank you. Can I now move on then to 8, the Chief Executive Person? Thank you.
Thank you. Just to cover off a few issues. So again, wants to acknowledge what I think we all know. We've been living through the challenging winter, and a bit like Game of Thrones. It feels a little bit like a never-ending winter in some respects, given what's happening. Because I think we all know if we left this meeting now and we went down to urgent emergency care right now, it would feel very, 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 very challenging indeed. So I think there's something about recognising and acknowledging the ongoing work that people have done and continue to do, not just in the hospital settings, but also in the community and wider. I think also in the report, we talk about the NHS recovery. I think it is important for us to understand certainly where we were post-pandemic and where the movement, the progress that has been made since then in terms of recovery, particularly around elective and cancer appointments. Nobody, I think, is saying, oh, well, that's job done then. I think everybody accepts that there's quite a lot of work that is still required, and the same for the Northern Care Alliance. But certainly there's something important about acknowledging, I think, the progress that's being made. I think also it's just worth also just highlighting the fact that at the announcement that Amanda Pritchard is now choosing to step down as of the end of this month. I think it is worth highlighting, like lots of commentators have, that it's been quite a tough gig, as I would call it, for Amanda, and under her leadership, coming through the pandemic, trying to rebuild on the back of that, I don't think is any easy feat. And I suspect 10 or 15 years from now, when we're looking back, we probably will place even greater value on the leadership shown during this period of time. She's going to be succeeded, certainly in the transition phase, by Sir Jim Mackey. So Jim is known to us. I was just reflecting, Jude, that kind of in the middle of 2022, Jim Mackey became a part of your and my life, certainly, in terms of backlog recovery and so on and so forth. And he's had that kind of national role. Obviously now he's going to be going into the broader sort of leadership role. I think the first kind of messages that are coming from that are very much focused on some of the performance elements. Money is going to be a primary consideration, so we'll be discussing some of that today and what that means around that. And particularly if you also listen to the new chair of NHS England, an emphasis on quality as well around some of that. So I think it's just worth us understanding that. A few other items, just to say the staff awards, for those of you who went, is a really uplifting experience. I'm hoping that we can get now back onto an annual cycle because this last one was a little bit longer from the previous. I know it's very, very difficult when you're talking about money and so on and so forth, but these events were wholly sponsored. They're not being driven by the taxpayers' pounds per se. But I think if you see what the meaning is to colleagues who attend these events and how much it means to them, I think it's really important. And I have the indulgence, as you did, Chair, of being able to nominate somebody, particularly from a chief executive perspective. And I think Dr. Hamish Hunter really does epitomise He only said to me, well, what we're doing as is the clinically led model to look like. I'd probably just get a kind of a picture of Hamish and say a bit of what that person does actually. There's a real kind of exemplar around that, and it's made such a difference to so many patients through his leadership. A couple of other things you could talk through. Freedom to speak up. So we're moving from Tina, who feels for me personally like he's been a soulmate. I'm the same territory as I would be with Jane, in respect of what it's been like working with Tina. And now we've got Shavana, who's going to be taking a lead around freedom to speak up. And, you know, Shavana's also very, very passionate about making sure that, like Tina, that everybody can feel that they can access freedom to speak up. So I think that'll be important. And then just all the final sort of points I make is just around the getting it right first time. We have, and I was speaking to Tim before the meeting started, we've had an invited review around in gynecology, which again will be a subject I'm sure we'll talk on today, and we are progressing that work. Happy to have any conversation with colleagues around that. We will certainly be having a conversation, I suspect, about spinal and the role that GERD potentially could play in that. But just to say to you, I was earlier this week part of the ophthalmology review, GERD review, and I can't stress enough colleagues about how we are now getting rigour into this process. So, you know, we've had a Salford Theatres review, we've had a gynae review, we've got an ophthalmology review now. And what's really important about these sessions is that they are an external expert who's expert in the area. So the ophthalmology example, who's expert in the area, sat with our colleagues, working against the self-assessment that our colleagues have done, the data that we've produced, and then having that time. and positive back and forth, but then that work gets construed into an action plan. And we have a process where I sit as the senior responsible officer, and the action plans in effect come before myself and the team to make sure that we're getting progress around some of that activity. That is a very encouraging process as far as I'm concerned, because it starts to get to some positive movement in terms of colleague wellbeing and also patient safety. And then just finally, and we'll touch on this in the finance bit, I'm sure, is the Great Manchester ICB. I think the Chief Finance Officer, Kathy Rowe, probably coming to realise what happens when you say things and the media are sat there. So Kathy, I can say she reported it, so I'm not saying anything out of scope, but she talked about in her 40 years of experience, it's not been her experience to know that, for example, commissioners are short of cash, and this has been a new experience for her. And then it was also discussed on the board meeting that took place last week about the gap that still remains in respect of and being prepared for 25-26, but also the challenging targets around backlog recovery and urgent emergency care that exist. So again, I just press back for now and have to take any other questions.
Thank you very much for your input. The executives report. Are there any comments or questions? As to note, the chief. Oh, yeah. Sorry. Chris.
Thanks, maybe. Thanks, it's really helpful actually, to see the context of some of the things that we'll talk about later on. On the GIRF, which, as you said in the report, is a really robust external validation, scrutiny of what goes on and provides that sort of external assurance. I guess I was just thinking through how we make sure we get sight of that, or it's not necessary for the board to see all the details of every bit of it, is it? But some of these things I think are worthy of board attention. So is there a process whereby we get to see that and have us be aware of some of the good things that's said in these?
Yeah, so in the governance, Chris, how it sits at the moment. So if you imagine the service area of speciality produces an action plan, I kind of get sight of that as the SRO and both challenge and support the progress of that. That then goes into a forum which Jude kind of leads on around quality and performance, and then that leads into QPC as of necessary on that. So that is the line of sight around that. But the role that I'm fulfilling is actually a role that, if anybody Googles it, there is a GIRF toolkit that talks about the process you would go through, and we're mirroring that, but the governance bit is into the forum that Jude would chair kind of managerially, and then into QPC as and when is necessary.
Chris, please.
Yeah, I was just curious, and I think like Chris, it's great to hear the background on some of these things. So the staff awards one was the one that created curiosity for me. You mentioned about Dr. Hamish, and it sounds like he's doing great work. And I just wondered, are we involving him in the CLM work to help us learn from him, and are we building the model?
The short answer is yes. So we have him and multiple other clinical colleagues who are contributing in different ways, supporting the design groups that we have and taking the learning as well.
Because I think maybe it might be good to hear from him at some point, so we can learn from him. It sounds like he's doing some fantastic.
He has already been to one of our workshops as well. So yes, he has. So it's some of the dermatology work. He hasn't got much after glasses, so we'll make sure we.
No, great.
Thank you. So just so the colleagues know, I'm not really fumbling, but I have the team numbers, but I don't have a little who's sitting on those seats. So if I missed you, then let me know. Just put your hands up high. Thank you very much. Thank you. I mean, that's a really comprehensive report, so much appreciated. I think the board should acknowledge our thanks to Amanda Pritchard, especially because during the COVID year time, and also those it's done tremendous leadership on the very difficult circumstances. So it makes a very warm welcome to our new colleagues, Jim. It's always it's Mackie. Because they're K, it's Mackie. But also further reaching out, we are very keen and encourage the collaboration piece to strengthen what we're doing, to improve what we're doing, working locally across 3M, but also working nationally and speaking up those reviews, which will then have them enabled to improve further, and more importantly, sustain the improvements that we're making, which is what we must be a conversation now and also going forward. So thank you very much for that. Before we move on to the integrated performance report, colleagues will now move into a range of different reports from our colleagues around the table. Can I just ask and encourage you to please highlight those things which are going well, those colleagues or services you'd like to commend, embrace and perhaps contextualise some of your thinking with what you're going to share to the board with, yes, the challenges and where we are seeking assurance, but also where some of the difficulties are presently causing some challenge, but you are mindful and confident that we're going to get over the line. I know that they are contained within your report, but I just think that emphasis is really important because we've already had from Myriad that do we extend the learning like we have from the patient experience report right at the beginning? And do we extend that learning in our thought process when we're presenting this paper? And where we're seeking outcomes and better delivery of our care and our quality of care and more safer care to our patients, service users and carers, and indeed to our colleagues who work across the NCA. So with that kind of encouragement, may I ask you to present the integrated performance report?
Yeah, thank you, Chair. So this is called a kind of balanced scorecard for a reason, and I suppose it's that any one of these metrics is interconnected with a series of others. And, you know, I will start with our people first and foremost. In saying that, again, another challenging month. This is January data. I don't believe that February data is going to look any better than this. But a challenging month for our ability to keep our staff well and healthy and importantly in work. And that does have consequences for us. It has consequences for us operationally. It has consequences for us in the quality of the care that we are able to deliver. If then we're reliant on temporary staffing, and that in turn has a consequence for us on the money. So I said it last month, I'll say it again this month. That is a kind of really key, for me, red flag indicator across all of this performance scorecard, and one that we collectively need to pay attention to. I think if you look at then some of the quality indicators, we need to watch carefully those harms with moderate, those incidents with moderate harms, and certainly things like pressure ulcers that look like they're within statistical control limits, but look like they might be increasing. So just things to watch for us, I think, as we are struggling with some of our capacity. It's certainly from an operational perspective, has been impacting us since the Christmas period in particular, and not least, as Owen said, because urgent care remains extremely challenged. We have been in and out of our full capacity protocol for what feels like several weeks. We recover, and then we get very overcrowded again, though, and often what happens is we have significant gaps on the rotas. So we'll have significant gaps in critical care in the emergency department in terms of our staffing ratios, or our, in particular, our registrar gaps. So it becomes particularly challenging for us to manage and maintain that patient safety in overcrowded departments. And then that has a consequential knock-on impact in the cancellation of planned care. When from a priority perspective, we're trying to decompress our EDs. So I think overall, if you look at the scorecard, to say that we are in the final quarter of the year here, with having delivered a significant CIP, I would say is fairly pleasing, if I'm honest. We won't get to exactly where we want to on all the indicators. I suspect that our very longest waiters, our 65-week waiters, will not get to zero at the end of this month. We had 38 in January. I think we'll end up with a similar number, if not a few more in February, because of cancellations on the day, staffing. But you know, significant reduction in our waiting list overall, and a benefit for our patients. We will drive hard, and the teams are driving to get cancer performance where we committed to in our annual plan as a priority for us. So working really hard with the dermatology team on that. And urgent care, we'd had a conversation here about the 78% target that we'd set for ourselves at the start of the year, but recognising at a point in time that 72 was probably more realistic. We are in the middle of what's described as a March sprint. So if we didn't feel like we were running fast enough to keep up over the winter period, we are required to run a little faster in March. Colleagues from around the table will remember there was a similar ask from NHS last year. We've not had a great start to March, it's fair to say. I have the pleasure of being on a twice weekly call with the ICB, looking at daily breaches to our target of 72%. And then there was an escalation up to the chief executive on those calls. Should I not be able to get the breaches under control? So that will be an additional pleasure for us. We continue to be a part of the Tier 1 ICB regime. We had that call with the national team yesterday. Actually, overall, I would say people were reporting quite positive things from across the organisation. Certainly, without a doubt, there is a lot of work going on, not only this organisation, but across all providers. That was evident. Translating some of that action into results, though, I think continues to be challenging for all of us. And there are some really wicked problems for us to face into as we step into next year. And one is really about finding a funding model for the ambulance conveyances. There was uniformity across the providers in testing the model, that it works, and there is an opportunity for us to keep patients in their own homes, which is better for them, better for their families, if we can make that happen. And it certainly decompresses our EDs. But finding a funding model to do that, I think, is still the big question for us. There was also lots of positivity about connecting that and the work that we can do in our communities, the virtual wards. We know that it's likely that funding will be deflated in this year. So some of that left shift that we describe, we can see opportunities to do it. I think it's about how do we left shift the funding at the same time in order to support where the capacity requirements are and where the demand will go. So one for us, I think, to work through as we think through our annual plan for the year and what are the improvement actions for us and how do we square that off with the financial challenges that we will have. I think there's not much else I want to pull out of the report. So the sickness absence rates would be a concern for me. I think we've got to watch those quality metrics really carefully in light of the challenges that we've got as we step into next year in particular. Diagnostic performance is the other one. I don't think we'll quite get it over the line to the 95%, but at the board, we did see that we benchmarked fairly well. So the target looks like we might be short because of echocardiography in Salford. We were a little late with the business case in year, and then we've had some significant demand that we've needed to catch up on rapid access chest pain clinic that's absorbed some of that extra capacity we put in. So we've prioritised that from a safety perspective. And the other exec colleagues might want to just come in and add.
Thank you very much, Jude. That's really comprehensive, and I appreciated your focus on making sure we keep a very close eye and focus on quality metrics, particularly those where trends are emerging. And I did highlight the pressure ulcers, which is a really good example. Actually, Aziz, please.
So I think
Yes. So.
thank you. I think I'm just also add though. I've been on 2 national calls now where Jude has been speaking about performance of the Northern Carolina today that Jude's talked about, and then a couple of weeks ago one with Professor Tim Briggs as a part of the past 20 group. I just think it is worth the board knowing, and it's down to the work of Jude and other colleagues, that on both those calls, there have been people from other trusts as well as national leads talking about the performance of the Northern Care Alliance, and also referencing the fact that they have come and borrowed work that the Alliance have been doing. And I just think that is important for people to understand, be it in context of content that we have later today. When people are in the national forums, even though there is an understanding that we're not where we need to be, the Northern Care Alliance is being referenced very in those scenarios, and I want to take the opportunity of just sharing that as well.
Yeah, thank you for listening. Please highlight those things that you are going well, particularly to colleagues, to Jude, and to you, and to you. It is can't understate it's when you have knowledge at national level. We can challenge trust, and we are still challenged for the recognition that the work we are doing is driving some improvements. They may be small, they may be not so significant, but definitely going in the right direction. That's a recognised board level too. I believe it is now Lorna, according to the list. Aziz, number 10.
It's me, not Lorna. Yeah, thank you, Chair. Thank you, Jude. I think that's quite a stark and accurate picture of where we are. I'm pleased that you focused on sickness, actually, because that's something obviously on People Committee I think we need to talk about later in terms of the actions, and I do wonder if there's some sort of step change in what we need to do on sickness, actually, because it's been a slow, steady rise. Obviously winter's made it worse, but I think during the committee notes, perhaps we can take that up and talk about it. What I wanted to ask is about the star factors and about the robustness of the data, because I noticed I've never concentrated on it too hard, to be honest, before, but did this time because of the figures on sickness. And I noticed that in the top left corner, a lot of the People Committee data is red for sign-off and validation. Is there a named accountable executive who can sign off the data as a true reflection of the activity? Has the data been checked for validity and consistency with an executive officer? And in no other group are there so many reds for that? And I just wondered, I'm not aware of this issue. So is there an issue with the data or the sign-off or the validity? What's the issue with the data, HR data?
Yeah, I'll let Gertie answer the question, but actually I did pick up there is a discrepancy in the data if you look at it, in what this scorecard is telling you and what your AAA is saying. So this scorecard is saying that our sickness absence is over 7%, and the AAA is saying something. So there is definitely an issue.
That's an annualised figure. The 6.6 is the annualised figure. 7.7, because we deal with annualised figures a lot. The 7.7% is the in-month for January alone, and obviously for December, January, February, we've seen just the winter a big run.
Gertie might want to answer how the data sound. So the kite marks, the quality marks, are a relatively new issue, and I picked up in December they were all red, and they've been added without reference to myself or my colleagues. Estelle is working through with IT colleagues at the moment to validate and verify that. So at the moment they haven't been verified, but there is a lead accountable officer, and that's myself, which Estelle is working on my behalf to resolve. Because from my perspective, they should be primarily green. I think we can have confidence in our people data. In respect of the difference, due just for clarity for other colleagues, 6.69% is a rolling 12-month average. We also look at the in-month performance because we will see greater shifts in months. So the 7.7% is an in-month. Our sickness, as we described last month at the workshop, has drifted
since 2023, in fact, but the period we look at in People and Education Committee is from January 24 onwards, and we see a steady incremental rise month on month. There hasn't been a material shift because of the winter pressures, nor was there any material shift because of the new policy introduced in the organisation in the summer of 2024. What it does give concern about is actually the operational activity in terms of supporting those colleagues who are off sick, and that is something that's being picked up actively through the senior management team. So in terms of the step change, for example, Aziz, that is a step change. It's not an item that we've had material discussions about in SMT up till now, or at least not that I can see. So I'm hoping that probably answers it, but do come back to me if I haven't resolved it all.
So if I may, no, I'll come at the end, but I have a comment to make about that. For now, can I ask Marianne and followed by Juliet next?
So I missed it in January because I was dining in and things were not very easy. But I wanted to recognize the team, I guess, between Jane and Jude. We gave lots of feedback around how we review these. We need to start with the overall picture and then go into the detail. And I know that's taken a while, but I think it was implemented in January. So for me, it's really great to see that we are starting with a top level performance, and then we start to look at which other areas that we need to focus on. Of course, being mindful that there's some improvements to be done, but I just wanted to recognize that the team has done great to implement that.
Thank you. Jeff.
Thanks, Jeff. Jude mentioned the opportunities to shift from our hospitals to the community. Quite rightly said that needs to be accompanied by a left shift in funding as well. I know we've agreed that the board will have a discussion on the use of the Better Care Fund. When will that happen in relation to our budget for the next few years? And are there any other opportunities beyond the Better Care Fund to address that central question of left fund, left shifted funding?
Yeah, do you want me to just answer that? So, thank you. We have had a discussion at Borough Localities Partnership last Friday about the Better Care Fund. We probably caused a ripple in asking for board line of sight, because I think there's a view of, well, we discuss it all locally with our care organisation partners, but I think I was clear to say it's about some of the parts as well and looking at it as a whole. There is a lot of narrative coming back from our care org directors and local authorities about the deflation of the Better Care Fund this year already, so they're taking hard decisions about what they have to deprioritise in year. But what we have done is asked for a collation of, I think SDF funding is disappeared this year. So there's Better Care funding and there's discharge funding that's available to us. So we've asked for a collation of what are the schemes in each of our localities that those funds are supporting. We linked it to a conversation about our exercise facilitators and the discharge front runner programme as well, because we haven't quite got a route to fund those. Craig and I been having those conversations, and we couched it in the conversation about the ambulance conveyancing as well. Is there an opportunity to do something? So we'll see the collation of those, and then I think Craig and I will just need to sit down and look at from if we've got some agreement about what's funded in each localities, where are our gaps, and what's our opportunity with our budgets this year to say, is that really important for us? I think what emerged, Jeff, from the conversation, if I'm honest, and I think this was stated, is there's a lot of rollover of permanent schemes or services that are supported by non-recurrent funding, such as the Better Care funding and the discharge funding. That was apparent on the call. What's less apparent, and I think there were local authority colleagues in agreement with this, is the effectiveness of all of those schemes. I think because they've been running for a while, we don't quite have the measures of effectiveness across everything. And so that might be something we just need to get into this year, because when we've got to decide, do we keep backing that horse or do we pick a different one? We need those measures of effectiveness.
Well,
Yes, please.
I agree with that. If schemes are working, it should be shifted to the mainstream funding. If not working, stop them, use the money for another innovation. But that doesn't seem to be happening.
No.
When do you think the board will get sight of this work?
So we will, what I will endeavour to do is have it all pulled together when we have the final annual plan sign off, see it in context.
Yeah, and thank you for that question, because it follows through with the board development session we had, where we were looking for that alignment and looking forward to seeing further iteration of that conversation. Juliet, please.
Thank you, Chair. Just wanted to point out from the performance report, there are two, under section 11, we go into a little bit more detail around perinatal and patient user experience. So just kind of drawing down from John Lane.
Thank you very much for that. And actually, it's a reminder to all of us that some of the elements of the integrated performance report will be discussed within delegated subcommittees, which we'll come on to. Thank you. Craig.
Yeah, I was just going to pick up just a few points on the funding models that Jude made reference to, and that's right. In some cases, what we've found is there isn't a funding model behind it, but then more importantly, it quickly gets onto a conversation about affordability. And it's just a point around, we're going to start shifting the money around. It's, we're reminded several times that there's only one pot of money now, and we're working as a system. So we have to make some decisions as providers and the commissioners to say what we're going to switch off to point the money in this direction instead. And some of that work will be expected to be supported by national productivity packs that's been issued to each trust in the country. And Jude and I agree we need to provide a trust response to this through the appropriate committees. And we were talking in the language of cost per pathway and trying to understand where relative gains can be made. Because the expectation is certainly about getting more out of what we've already got rather than expecting, more nationally. And I think some of that will come out of work that Owen has already mentioned around the GIRFT and what we can factor in to that. But certainly we need more clinical engagement on that cost pathway piece, and performance and planning group and finance committee are certainly going to delve into that. And I think we should get used to the phrase, and hopefully, our mantra will be, where's the evidence to support that? And let's make some evidence-based decisions. And we should all be sick of that phrase soon, hopefully, because we should keep using it in terms when it comes to some of these productivity measures. If we're going to justify things business case wise, the evidence base there will be key to allow the ICB to prioritise where the funds need to be. We need to be on our A game or being with that productivity evidence base.
That's a really good point, and it's one well made, and it is something that we are mindful of and revisit enough and do the chicken challenge, because we make as a board evidence-based decisions based on what we see, what we data and we see. If there are gaps in that information or in the data and if it's not aligned, and we've spoken and didn't describe the in response to Aziz's challenge, because I circled that last page as well. It just doesn't read right. But the alignment of data, the consistency of assurance that comes from it can only emerge if we provide that oversight. So there's a work to be done, particularly from the executive team and from their support, to make sure that we have that triangulation and that we retain our focus on the evidence base. But also, we need to reimagine some of the cost per pathway. The cost per pathway, actually, it's the outcome of the pathway, isn't it, really? You're using the evidence base because you have a pathway, there's an outcome you want to achieve, which is around higher quality of care, a safer patient experience, improved patient outcomes. And being all up to that is the access issue that we have reiterated many times. But just before we move on to the next item, the left shift is all about, it includes care back into the community, in our localities and our neighbourhoods. It also encourages us to think differently about how we see prevention and through what lens and how global is it. And I think we are quite global, but not at the moment, just bringing everything together, which is a challenge in particularly in the context of the evidence base. But I genuinely believe if we reimagine what that looks like for us as a care organisation, and think, well, if we had to put a cost and maybe that's more time and not really money, our investment would improve patient outcomes, it would improve colleague experience, and there would be a redress all the issues we've described already. Now, I wouldn't want you to lose sight of being strategic in your thinking. Not our focus isn't just about being operating, it's about being strategic, widening the lens, and certainly coming back to how we present that information, the focus required. And also, yes, the challenge, but the opportunity that we're going to see alongside it. And finally, working within that partnership arrangement, actually, I think we can lead on many things because we have the knowledge, we have the expertise, and we have that colleague aid. So just ask you to reflect on what I've just said as we move forward into the remaining agenda. So if I may, colleagues, can we move on to agenda item 10, which is the finance report. I'm going to invite, well, Sue's not here, but Tim, you are going to step in.
Yeah.
And thank you very much.
Yeah, there are two AAA reports, two meetings took place, one 24th of January and one last week, 27th of February. So if I just talk to the 27th of Feb, but obviously if people have questions on the prior meeting, then please ask. The two major items considered related to the financial planning for 25-26 and the financial position at month 10, including recovery and cost improvement. So if we turn to the planning piece first, because that's in the alert section. Now we will be looking at this at part 2, but it's kind of important as well to flag here. You can kind of see set out there that the board has already seen the planning session that at present the deficit plan submitted by the NCA is 96.9 million. But it's set out there that the control total issue for GM ICB is 200 million deficit, 150 million sitting of that with providers, and our part of that is 57.9 million. So, effectively that's a further gap of 39 million. So Craig has set out at the Finance Committee, which we scrutinised there and we'll look at again today, a potential path to closing that gap. But without going into detail of each, clearly that puts simply significant pressure again on the cost total, which we can see at the second to bottom bullet point, raises it to 110 million, 5.6% of gross expenditure. So, the challenge is there. So the Finance Committee has kind of looked at that bridge. Further work needs to be done on it, but I think it's important we corral in the minutes perhaps kind of the journey so far of the board having cited this as a planning session of Finance Committee and talking to Craig, other kind of checkpoints that are possible before the next submission. But clearly the SIP challenge and as yet a lack of line of sight to kind of the implications of that in terms of sort of whole time equivalent and those aligned to particular schemes is not there yet. So clearly a big challenge that we continue to look at collectively as forward. Advise of areas of ongoing monitoring or development. We'll be taking a month 10 report in a moment, so I won't go into the detail of that, but clearly the very, very significant achievement as we come to the year end is around the SIP delivery. So we can see there, on a full year basis, 88.3 million. I think I may be even a bit higher as we come to the year end. has now been identified against the 4-year target. So this transacted and identified SIP is a tremendous achievement. And clearly we've given assurance, and Craig has to the Finance Committee and to the ICB that we're on track for delivery of our revenue and our capital plans. Just one additional risk that's in the report, that there's a piece of work going on around looking to convert current SIPs, non-recurrent into recurrent, and that the Finance Committee will be looking at that work in March 25. So those are the main issues. That the approval piece is coming to part 2, but it's kind of logged here in terms of the Cisco end of life business case. So that's the AAA report. So a big challenge, but important to kind of log the Finance Committee's line of sight of this as we move to the final submission date. So certainly take any questions.
Thank you very much, Tim, and you've logged that connection. Yes. Jeff, please.
Thank you. First of all, apologies for missing finance committee's first one admitted actually since on the board. Suppose changing the date of the meeting. The SIP target here of 10 million per year is clearly now a lot larger than the previous plan, which was 85 million in each of the 3 years, last year, this year, next year. So I suppose the question is, and I'm happy if Collins will deal this afternoon, but the question is what this new target means for our financial sustainability plan. Are we on track with that plan and it just gets a bit harder, or do we need a new plan? And I think in particular about the overall strategy on cost improvement. Had discussions in recent months about whether or not current approach, which is basically a whole myriad of effective cost improvement schemes across the whole organisation, which really do work and add up to a significant amount of our target, or albeit not all non-currently, whether that can work for the second year or whether we need to move to a more strategic approach. Now I've got as much of a target, that question must come forward again. So basically, is the 3-year plan to be continued, or do we need to do?
Yeah, I mean, I know it's one of the principles, isn't it, Craig, that you shared with us. So
yeah, jump to yeah. So I think, Jeff, I think we've always said financial sustainability plan as a map out, like you say, 85.6 million for the next 3 years, based on a number of assumptions that we've always sort of talked about, not least of which around our income expectations within that, because there's moving parts on that model. I would just describe one example of a moving part that wasn't factored in that would affect that model is an extra 0.9% national efficiency in the planning guidance that we alluded to at our development board session. Now, for us, just as a standstill, nothing else changing, that's a £17.8 million impact on the NCA. There's no way that the model could have ever seen that, could have ever predicted that, and there might be other changes in income. So you only need 2 changes of that order and you're into 1 or 2 financial years difference in terms of getting into that break even, unless you start to affect or change your CIP expectations. So that's the grapple that we've got with the safety valve to a break even, maybe will always rest in changes like that in that CIP. But that has a certain tolerance, as we know, certain risk appetite that we need to sign up to if we're going to either try and hold the line on the original timescale or justify an extension to the timescale on the grounds that national assumptions have changed and affected the model. So I think that's a long-winded way of saying, Jeff, I think it's an iterative piece, that FSP, based on the assumptions changing.
Yeah.
But there are, in Craig's answer there, some very clear choices for us. Yeah. I suppose the question is, are we making these choices this afternoon? If not, when we'll make them. I would prefer not to do this in an incremental sort of look-through way. I prefer the board to have a really in-depth discussion and then make some choices. So it's just, I suppose, a processing question.
Yeah, but I think we will definitely be discussing the next iteration of the plan, Jeff, this afternoon, and there are some options in there for us to take, forward. So depending on the discussion,
Yeah, your points are very well made, and we have captured that and got to further discussion because of the fluidity, because of some things that we can do, something that's kind of sort of wavering. But put it that way. Thank you. Tim, so you presented both of your finance reports updates. Can I set the board acknowledges and notes that we have received those both those reports, and we move into Craig, your reports.
Yeah, I'll just pick up where Tim left off really, but echo some of Tim's points around CIP. But essentially, and I know the details there. So essentially, the good news, if we focus on the rest of this financial year, which is not much left off, but we'll say till the end of March, that following the board giving assurance to the ICB that we will hit our target, I have no reason to believe sat here today that will not materialise. So I think we will hit our target of the 4.3 million deficit, which is predicated on a delivery of £85.6 million CIP transacted, which I can say today has happened. We have transacted that level of CIP. And I think, sat here today, that's an enormous achievement. I'd like to formally thank all the SROs that are involved with that work very diligently on these programmes of work, and the people who support those programmes of work. Really important to formally note that public board for all those people out there that has worked diligently on these programmes of work, not least of which the steer that we've had from the likes of Nicola Bailey, our CIP director, and Joe Gibson, our turnaround support in some of that. So I'd just like to formally acknowledge their efforts and everybody else's in the delivery of that CIP this year. In terms of capital, we, as Tim said, we had a discussion at the Finance Committee because we were behind on our capital plan in terms of our spend versus plan. But again, I'm pleased to note at board, just this morning, I've been assured that we have orders on the system ready to go that are now in tune with spending our full allocation of capital that's stated in the report of 63.4 million. So we've got some assurance through the ordering system now that will fall in track in the next 3 weeks. And then our cash position remains relatively healthy as a result of the injection of cash we had earlier on in the year. We're at 79 million, which is about 16 days running. So we don't anticipate any cash issues for the rest of this financial year. So those three things combined have meant that 24-25 has been delivered from a context of finance with the CIP we planned. However, we know that the way that we delivered the CIP in terms of the recurrent and non-recurrent nature and what we were trying to deliver didn't stick as the original plan, and we had to do a forecast, if the board recall, at around month 8, a reforecast about how we might achieve our position in a slightly different way, which we have done. However, that leads on to how that impacts into next year, and that's that discussion this afternoon about how we need to adjust our expectations on whatever our CIP target has to be next year, around a decision around the recurrent split and non-recurrent things like our pay bill reductions that we need to consider and the schemes that we have in front of us at this present state time. So, but that will be in detail this afternoon, Chair.
Thank you very much, Craig. Are there any comments before I conclude that? Can I? Yeah.
But I just add a broader comment, Chair. So, in terms of GM, as Owen described, there's some contextual stuff that if we hit our target, which we will, the 4.3 million deficit, the system itself as a break even will not hit a break-even target, and the board position from the ICB perspective is it will hit a deficit of 69 million. That's what's currently being posted publicly at the board, and Kathy's just confirmed that this morning with me. So we are expecting that will be accepted, but as a system, we've missed our target by around 69 million. As a trust, we've hit what we said we'd deliver. Thankfully, that does not materially affect next year's planning assumptions, because in the annual planning guidance, one of the rules that NHS England set was a £100 million tolerance on the control total for 24-25. And because GM has missed it by 69, they are within that 100 million tolerance. Therefore, we pass go, so to speak, into the planning round for next year.
Thank you for that. It kind of just, it's the right word, it grounds you, doesn't it? It clearly, let's go, it's the amount of work that has gone into delivering RCXB and absolutely exceptional. And I know that you were very, as you always are, inclusive in how you acknowledge all of our colleagues who have been working very steadfastly, very robustly, with a clear focus and highly motivated to get this done, because we worked together at one NCA, quite right, through the respective SRA, I think, supported Nicola and Joe. But notwithstanding all of the people you mentioned, of course, credit must go to you too, for your leadership, Craig, and for your the way in which you have managed some of that complexity. And it's quite right, we did have to change tack, didn't we? We did have to adjust our forecast and reforecast, because that comes with some of the territory, some of the knowns, and some of the very big unknowns where we do the risk profiling. So it's up to thank you to you on behalf of the board, and everyone else you've mentioned. It is clearly a massive NCA achievements, and recognition should go to them. So can I suggest that we take a break at this point before we go into the QPC? So, colleagues, this is agenda item number 11. We'd like to colleagues to give the chair's report for the report committee for meetings that took place on the 20th of January and January.
Thank you, Chair. I'm going to start with later, if that's all right. And there's two sets of papers on the agenda. I'll preface things by making a number of points. I think it's been well made, the point's been well made already this week about the operating context of the work. Anything that I have to say or discuss, I think, should be absolutely seen in that operating and financial context that we talked about and we'll talk about more. Because I think it is relevant, and I think it is appropriate to say that in that context, certainly some of the data that we see here is actually remarkable in terms of its changes. So some of the performance changes that Jude has outlined, etc., I think are well worthy of note. The second bit of context for these reports is, of course, that the full record of the meeting is in the minutes. This is I hesitate to use the word highlights, but this is the summary of the report of the meeting discussions. So please, if anybody wants to see the detailed discussion, please go and have a look at the minutes. You'll see in the second of the two reports, that's the report of February. Sorry. So it's the meeting held on the 17th of February. If I start again with some of the really very positive things that we've heard about at the committee, and I'll talk about the sure ones, if I may. I'm going to talk about maternity a bit later on in the agenda, which I think we've already noted in the IPR, and we certainly noted at the QPC the wealth of data which is provided, and the improvements that have been I think I would say remarkable in terms of the data that we see in terms of maternity. I was particularly drawn attention to the external assurance by the LMNS, the local maternity and neonatal system, which provides this external assurance, particularly on the 10 safety actions. So I think we do have a degree of external validation of that data that we see. So I think it is worthy of note. There were two other things that picked out from the discussion that were very positive. We had a very positive report on the management of controlled drugs. There was some initial concern, I think, Rafiki, it's fair to say, on the issues to do with the disposal of controlled drugs, but our Director of Pharmacy came and provided what I thought was a really good report, giving us assurance on our statutory requirements related to controlled drugs, which is, I think, something of an indicator in terms of aspects of care. So that's one to point out. And the other thing to point out was infection prevention and control, which again we received very comprehensive reports, I thought, from the team, and I think it is important to point out to the board members that whilst when you look at the data, you will see increases in the number of C. diff infections and others. That is reflective of an underlying national trend. And not to say that we've been at all complacent in QPC on this, I've looked into this in some detail, but it is clear from the audits that have been done by the teams that the crucial issue in the NCA is medicines management and antibiotic, what is known as antibiotic stewardship, prescribing the right antibiotics for the right length of time to people. So, I think we got a report which gave us some real assurance on that. So I start as requested with the positive things there, Chair, if I can. In the advice section here, there's reference to the performance issues which Jude also would talk about further. But what I can't pass by is the very brief reference, but important reference here to volunteers, which you made reference to. I know we've got further information on that, but we did note with great thanks the contribution made to improve patient experience by volunteers associated with the trust. That leads me just to refer to some of the other things discussed at the committee in terms of the level of risk. I think it is clear from all the information we get in terms of back operational risks, etc., that the level of risk that the clinical and operational management teams are dealing with within the trust is high. There's a high level of risk generated by the sorts of pressures which, again, Jude has referred to in her presentations, numbers of patients, and so on. So we do see, in terms of this committee, 40 significant risks on the risk register. I think the IPR, Jude, was 70. And I think an area where we can tighten up is looking at the closure of those risks and the closure of the actions related to those risks. Bearing in mind we're talking here about risk levels of 16 and above, which is serious level harm organisationally. So I think there is something we can tighten up there. From the committee's point of view, one of our roles is to advise and assure the board about our compliance with regulations. And as I've said in the report, here taken together, that's something that we need to do more work on, and we will. We have started a sort of programme of looking at regulatory compliance, but we need to do more work so that we're in a position where we can assure the board about our compliance with the breadth of those regulations. I also draw attention to the quality governance system and very positive changes, I think, which have been implemented over the past few months. But it's not a system which is yet completely embedded, and I think we had a bit of a discussion about this at the at the meeting, but we felt that, you know, that new system of reporting does need more time to be embedded in order for us to be fully assured that it is working best effect. And we address some of the gaps which I think there are at the moment in the reporting system that we have. Internal audit reports. You know, again, a bit of tightening up, I think, here, in the sense that focus on when we get internal audit reports which have limited assurance and have high priority actions, making sure that we properly close those down and can be assured about that. There are two specific areas of service which we received papers on the at the committee, and firstly, reference to the aspects of gynecology which had been reported at the board here previously, where we heard about reviews which had taken place related to delays, or we heard about the process for following up the patients who've been identified through those reviews. I mean, wasn't a complete process, and we obviously will follow that again further through BBC. What I did, particularly as Daniel, who was there, behalf of the P who was away, are allowed to be away, I think. What I asked Daniel to do was to make sure that next time, certainly QPC, we saw this, we've got, as it were, the full picture, so we can see all the range of things that we're doing. The reports from steering groups are very helpful. What they don't necessarily do is give you a sense of the total management of an instance. Similar thoughts on spinal surgery, where we received a specific report about the exercise to look at the care of patients who have come forward since the Green report was published, and we heard details of how that exercise is being undertaken again. As I understand it, not completed, and I think they have more details to report from stage. Again, we asked for some further assurance on this issue in terms of details of that process and the outcome of it. Jude very correctly pointed us to the fact that the steering group, the overtime group, was in terms of not directed to report directly to the board, and I know that's something that will be discussed, and believe it's coming back later in some couple of months. I think it's the timescale. It's on the work plan anyway. Be done. In terms of my next patient policy, the UPC received the policy and scrutinised it and asked a lot of questions about it. I think our conclusion, other members of the committee will endorse or otherwise this comment, but our conclusion was that we thought that it was an entirely reasonable approach for the management team to be taking. We did ask that there be further assurance that the proposals and the implementation of the proposals met the requirements that the CQC had put in place and together. I noticed in the paper that we have later on the agenda, there's a specific table to that effect, which I think is very helpful to take that forward. So certainly in terms of the committee's review of that paper, there was an endorsement of the approach that's been taken. Violence and aggression standards, clearly a really important issue. We were asked to approve a number of standards for the management of violence and aggression, but we felt unable to do that pending the agreement of what the policy would be. It seemed to us that the policy came first, and then we could look at what the standards for implementation might be. And again, I know that's something which has been taken forward. Finally, on this paper, I just wanted to make the point. It's always a small one, but in fact, in many ways, a very important one. We do make some efforts to think about health inequalities. I think perhaps inadequate attempts to think about health inequalities at the committee, but we do make some attempts. And we did, and Aziz in particular, did notice this issue of services for looked after children in part of our area in Oldham appearing to be withdrawn, and drawing comparisons to the approach taken in other parts of Manchester. And that did seem to us that something that would exacerbate inequalities or discrepancies or variations or inappropriate differences potentially. We didn't have the full details, but we wanted to bring that to the attention of the board. I don't particularly propose to go through the first paper and to say there are one or two things to do with risks that have been on the risk registers for some time. And then when I come to learning, I suspect that out of the conversation at QPC, there is this sense of how do we collectively make sure that we've got all those risk issues covered and assessed. And back to the earlier conversation, we're not missing out on some of these things between committee and board, and also do we have common understandings of these issues of assurance, risks, and the approaches to be taken, and indeed the roles of the committee in terms of reference are very clear, but are we using them to best effect? Probably taken longer than my allotted time, Chair, but some of those issues are.
No, and you haven't taken longer than your allocated time. You can have as much time as you like, because this is a really important report, and our colleagues, including all of my non-executive director colleagues who chair the committee, do so on behalf of the board. And it's really important that you reflect the scrutiny and ensure that you seek those committees alongside your executive director colleagues. You've been very thorough and very comprehensive, and appreciate your candidates, and also appreciate the manner in which the development of the committees in terms of reporting is evolving to a much better place. As I said earlier, we do understand, we acknowledge that there are further strengthening is absolutely required, but we are such a very candid and open and transparent board that we can have conversations which kind of test those things out in terms of our assumptions, but also acknowledge when things are going well. I think we've had a combination of those things, Chris, from you in your reports, and certainly in the reports that follow from my other non-executive director colleagues. I'm going to just ask whether there are any comments or any further clarification that anybody would like to raise at this point to Chris? Can I just make a oh, repeat your sorry. Okay. Yes.
Thank you, Chair. Welcome the report and comments from Chris. I'm sorry that I couldn't be there at the meeting. Just a couple of things we need to highlight. The gynecology issues that we're working through and the spinal issues are subject to a piece of work and rapid quality review that we're also doing with ICB and NHS England regional office colleagues. So between working through QPC and the support that we get from them, we will make sure that we work through those. We have a short paper on spinal later in the agenda, so I'll leave my spinal comments to there, and we'll bring something a lot more comprehensive at next board. The gynecology piece is near complete. There's just a few things to tie off, and so next time we report at GPC, I think you'll find something a lot more comprehensive there, Chris. And I do agree with you that the new structure that Heather and I sort of developed in terms of quality governance requires a bit more bedding in. And so in Heather's absence, I've had some discussions with Juliet and with Tim just about how we ensure that we're working together over the next few weeks to ensure that there's a bit more robustness around that. Thank you.
Juliet?
Thank you. I just want to give a little update on the balancing question standards because we did have that conversation at the committee. There is work going on in the background to get the policy. It's very active work to get the policy where it needs to be. It's such an important policy for us at the moment in light of some of the things that have been happening. I want to make sure we get the right stakeholder involvement in that, including make sure we've got the right staff side representation in those discussions. So it's a little bit behind where we needed it to be, but I think for the right reasons. But in the meantime, just for assurance, for our other policies in place, that we'll deal with that. We just think there's an opportunity to make this better.
Yes.
So just want to get assurance that there isn't a gap there from a policy point of view. And then the other issues around the health policies for children and older, and that's still work that we are ongoing with. And there is conversations about where that funding may be, but we're working hard to have very clear conversations about what we think the needs of that population is. It will be keeping the committee up to date with where we're at with that.
That's a really helpful update. Thank you for that, Julia. May I ask Jen? Thank you, Rowena. It was just Chris within the report under gynecology. It does say the instant response is being reported directly to board. And I just wanted to clarify that will be via QPC, is my understanding for what the speakers just said. So I just thought we ought to just confirm that.
Yeah,
and if that's
sure.
the case,
Confirmation,
I think.
May I come back on that? I obviously wasn't at the meeting, so it wasn't part of the direct conversation. But that I think might have been a reference to the fact that we, if colleagues recall, wrote a paper about this directly to board in the past when these issues initially sort of surfaced and we were starting to deal with them. But I think the route via QPC is a completely appropriate route. Yeah, I'd be very happy to bring things to board if colleagues want to see them.
Yeah, that's a bit really. Yeah, we need to just be clear on that route. And I think the discussion which took place from memory was about whether UPC was seeing all of the strands of the gynecology issue or some of them. And I think it's important it sees a whole.
Yeah.
Not just, there's a danger, isn't there, that people sort of assume QPC is about the sort of very clinical bit of it. It's not. It's about the clinical care, the overview of that. So I think that's what that's about.
And if I may, very last comment, I think Chris actually referenced it earlier. The thing with gynae is there are so many strands to it. I mean, there are 5 what we call safety priorities, 5 distinct pieces of work, plus the work to bring the service together, etc. So probably 6 or 7 pieces of work that are running in parallel. So part of just the complexity is you can end up with bits of it in different bits of our governance. So yeah, I think a conversation about just how we consolidate that through one we can have.
It's whether you consider having a sort of, the different ways of doing it, but if you would consider having a single plan which you're able to use at different forums.
Thank you. Chris, Jane, just one thank you, Chairman. Chris, I recognise that it states within the report that you'll be reviewing the board assurance framework risk that relates to our quality governance arrangements at your next meeting this month. It was just to say, reflecting on the alerts in this report and the previous one, for those, the risk currently stands at 15, and therefore, in terms of
of how we prioritise matters from the board assurance framework. I wonder, is it sitting correctly now in that prioritisation? And that's for the committee, of course, to consider and report through to board. I would also encourage QPC to consider the are we effectively and proactively utilising our risk management arrangements within the organisation? Thank you, Chair.
Yeah, everybody there is very interesting. Thank you, Jen. Mary.
Just a reflection for me. There's quite a number of alerts on there that are around, we need more assurance, we probably have compliance issues, we need to take actions to make sure that these are closing out. What I'm probably struggling with is I'm not clear where those are up to. So, for example, the January one had the issue around the delayed, I can't remember which one it was, but something that was supposed to have been done in 2018 and has not been done for over 5 years. It says there's a plan to do it, but actually if it's not happened for that long, what's the plan and when do we expect that that's going to close out? So I think there's quite a number of issues on here, but I personally don't know when we expect them to be closed. A number of actions that the board needs to take, ensure that we have an action plan and the timescales are in
I think
place.
that's the question the committee was asking.
But I guess
That's the question. That's the question that the committee posed. And on the 2018 action, they were told that there wasn't a plan in place, but I think we would require further information on that to either to close off. But
I guess from the board, it would be good to know when are we going to get that response so that we have kind of
I think that's the question to the board for the team to answer.
Yeah, so and actually it's a really important one because we've had conversations before where we've identified that actions remaining open, go past their due date for the target due date for completion, and then extended it. The further you extend the date, the more likelihood of risk there is associated to that particular point. So I think I would like will you be able to respond to the action?
And for me, that one seemed like it's a basic thing that we should, if it's taken 5 years, then we really need to be closing that one out sooner rather than later.
Yeah, so this was a risk that had been on this one. This is the risk that's been on the risk register for some time, which was to do with washing facilities. It had been identified as a risk, and actually had what was reported to the QPC was that it had been addressed through the process and had been reduced, risk had been dealt with. The point being made in the report here, under the learning section, is I think around ensuring that we learn from that and we are scrutinising those risks in future to make sure we're not in the situation of, is really quite a basic patient infection control matter isn't missed in the same way in the future.
I think my overall point, sorry to push back a little bit, Chris, I think across a number of items, it's quite difficult to know when we plan to close those out. And I think even just giving a timeline to say, actually, that will be closed out by the end of March would help, because then
It's not quite what report is for, but I think I'll take the point.
Jude.
Yeah, if I can come in here, I think the issue of the wash basins, I'm going to say, came to the committee, but hadn't previously been a focus of a long conversation in the committee. That was something that was being escalated, that was unresolved. It's as much an issue that should be being discussed in the Capital Committee programme as it is in the Quality and Performance Committee. And I think that connectivity is missed, if I'm just being straightforward. So I think we need to take it away. It needs to be discussed in IPC committee along with estates teams and Capital Committee, and a very clear plan I'd suggest needs to come back through either Patient Safety Committee. I think IPC refers to Patient Safety Committee, is that correct? So I'm going to suggest that that's the route that it comes back, following a conversation with Estates and Facilities and Capital.
we'll pick that up as an action from the board as well.
Yeah, and what that actually illustrates is that some of the themes that we're looking at or we're looking at are discussed in other areas which are not within our complete line of sight. So there's something there, isn't it? It may be helpful if the executive directors, because we had this conversation as chairs of our various subcommittees, that some of this work spills over into people education, or it spills over into research and innovation. So how do we capture that holistic governance piece? So there is a real challenge there, how we get that right. And some of that must come from the executive team, showing themselves that the papers that they're presenting that come to board are actually accurate and up to date. And really, there's an opportunity there. But also to check and challenge each other where data you're holding but hasn't featured in data which should be complementary to or inform and improve an outcome decision at a closing of an action or not, as we've just described. So that's the learning that's taking place. I'm hearing that loud and clear. I'm definitely on that structure of improvement because it's featuring the way the boards are being presented with the paper.
And we now have the cross-committee connectivity section. So I think we now need to maybe try to use that, because I think reading most of the papers, there was no connection identified between committees. Whereas the discussions we are having are saying, actually, there's some things that need to go to different committees. So maybe that's an action to make sure that we are clear on things, stuff that's transferred from one committee to another, that we make sure that those connections are there.
And that's a really good point, because that's what I do. And we all do that, because we know, read it over here. Oh, but there's explanation over here, but shouldn't it be here?
But
So
a lot of it takes long.
Yeah, you're right. Thank you very much, Maria. If I, Julie, coming back.
Just on one point, just
Yes.
on the time frame you're referring to, I think when Rafiq mentioned we'd had those conversations about how we spoke with Chris on the team about the time frame where everything will get into a better shape. Accepting that the structure has changed, which we think is a good change because it allows a better line of sight. We're thinking that we'll be in a really good position in the next 3 months, but we'll be in an improved position in the next 6 weeks. So that's the time frame that we're working to. I think the point about the learning will be that we try to take into account some of the things that went in this conversation here. And so we're really clear about risks and where the management risk is, dependent on where that presents itself in terms of in relation to patients. So that would be, I think, where we would expect to find ourselves.
Just after that, I think we're anticipating that over the next number of months, as the papers that the committee receives start to answer the question as well as pose the question, we'll be able to see those timescales in a better way. I understand the point.
Yeah, but I think being clear on that, then we come back in 3 months and say, where are we against what we expected to do with the group?
Thank you. So really helpful discussion. Before we conclude the QPC paper, can I please commend our volunteers? We often talk about our patients and carers and service users experiencing, we talk about our colleagues, but we do often have the opportunity to celebrate and commend our volunteers in NCA, and absolutely fantastic. And not only do we feature nationally, as number 2, but within Greater Manchester as number 1. It's a massive achievement, and I would like, on behalf of the board, to say thank you to all of our volunteers who work tirelessly. They're kind of invisible amongst them. They're all like the wallpaper, they're invisible, but they're so important. They add texture, they add life experience, they enable people to feel comfortable and have clarity about where they're going or where they shouldn't be going. So I'd just like to give that to be noted in the mix.
Chairman, sorry,
Yes.
There's one point I'm sorry, I've omitted to bring specifically to the board's attention, which is the issue about mental health support in acute settings. And I do think that's something which needs noting, but I know the executive team are continuing to have those discussions. I think there's a big gap in the current support arrangements, and we to think about that. We did say we would come back to this issue and hear updates on it, so it's not lost.
Yeah, and again, that's a really important point to acknowledge. Feedback is what you were saying earlier on about colleague wellbeing, and actually the patient experience story. The quality of scene that we need to give between mental health and also physical wellness. Comment.
Can I just add about the volunteers piece?
Yeah.
I think it's absolutely amazing that we've got so many volunteers and we rank where we do. And I do wonder whether we've even undercooked or underreported the amount of time volunteers put in. I did some volunteer patient dining companion work, and after the initial training, I was able to just go on the ward and do that companion work, as many of the companions do, and it's not recorded. So I think we've got a lot more going on than we even have recorded, and I think we should pat ourselves on the back for it.
Yeah, no, exactly. And that sort of thing, maybe we need to hear a lot more about. But certainly, the acknowledgement needs to get out there and communicated during. Well, thank you. Craig, is your hand up?
I'm sorry, no.
You just rested.
Just resting. In thought.
Okay, we now move on to matters for escalation, which is the learning from patient and secretary's experience, including complaints and patient advice and liaison services. Juliet.
Yes, thank you. So this is a quarterly paper. This relates to Q3. It's quite a comprehensive paper. You'll see there's quite a lot of detail in the paper. I think the main things I wanted to talk about were the strategy achievements in year one, which I'll come to, and then some of the performance measures around patient and liaison service and complaint service. Whilst I'll talk about an alert, actually this is one of the real pieces of improvement that we've made, which is the observe, listen and act visits. They're going really well. And so the alert is just one where we continue to find a risk around it, the Bolton Renal Satellite Unit. So that continued to feature on our agenda, but it has been overseen, and it's great to we've got real active observation of that area, and that's why it's remaining a red for us. We have changed our visiting times, and we've also launched a Reducing Noise at Night campaign, and those are both going well. We talked a little bit about volunteers, so we're seeing some, as we say, we are providing an exceptional service to our volunteers, and they are making a significant impact. Just going through a little bit of the detail, the friends and family test is showing slightly lower than last quarter, but it's above the average from last year. And we keep talking about the questions the organisation, and the thing that it's coming through from our FFT is being treated with kindness, compassion, dignity and respect, and feeling safe. So really important areas, feeding back from those. In terms of PALs and complaints, we've got some really good data around first response, which I think is something that is really important to people when they're raising a concern with us. We've still got some work to do on responding to complaints in the timeframes we'd like to do in terms of resolution. So that is the focus of improvement work, and within the care organisations, we're keeping very close track of those performance data. We are seeing an increase in complaints and in PALs coming through, which obviously gives us concern on one level that we're getting complaints. But then there is the opportunity for learning that we get from patients, and I think we've used the services in taking time and effort to contact us and tell us about their experiences. So I think as long as we're responding well, we need to see that as an opportunity for us to improve. I think they were the main things really. I think the real improvement and the real impact of the observe, listen and act inspections are good position on friend and family test, and the work we need to do on our responsiveness in PALs and complaints. Any questions for that?
Thank you very much, Julia. Are there any comments or questions for Julia on this latest paper? The lights are on. So Jude and then Chris, please.
Yeah, thank you. I think we've got a real opportunity to, there's something about making the patient experience everybody's business in the organisation, whether you work in estates, whether you're a reporter, having a conversation with the patient, moving them from A to B. So I want to kind of connect some things for us in our minds. So the Noise at Night campaign, if we look, 40% of our discharges happen after 6 o'clock at night, and a considerable number of those happen beyond 10 o'clock and sometimes after 12. I think it's a real issue for patient safety to send people home in that evening. But it's also a real experience issue. We can't reduce noise at night and wards when there's all that activity going on, I think. So there's an opportunity for us, I think, to connect some metrics here with what we're trying to do with the patient experience team and clinically and operationally about, well, how does that give us food for thought about what we're doing, you know, in the clinical and operational space. So I share it because I think there's an opportunity for us to think about patient experience in its broadest sense in the organisation, and some of those key metrics about bringing the day forward, you know, and actually ensuring that, particularly at night time, patients get their rest. You know, we can put hospitals to bed safely at night and not think that we're operating 24/7 at that high intensity feels quite important. So I just do it because I think there's opportunity for us in the patient experience space to connect some dots for us.
I think that also needs to be aligned to the learning outcomes that we seek. So that there's a patient experience outcome or patient reported outcome, and that's aligned to a complaint. We need to see that triangulation because that could be enabling. It's also discharge delay due to patients and families waiting for the medication. So there are lots of different levels here, aren't there? Thank you for making us really good. May I ask Chris, please?
Sorry, it was a.
Oh, was that
It was a.
right? Jane, you had a nice one. Thank you. Jane,
Yeah, page 4 of the report at the very bottom of the page refers to the complaints review panels recommenced in October, and saying that the panel provides assurance to the board that complaints are received, you know, etc. I can't see that. Can't see those assurances in this report specifically, and I believe this would be the route for those assurances to be provided to the board. It might just be something that you want to explore for our next quarterly report, please.
We can certainly do that for this board report because there is underlying, there's obviously underlying data here, but if it's helpful to see that coming through QPC's board, we can certainly do that.
Yeah, and I would like to reinforce that point that I was going to make it as well. I think the complaint section is limited in providing us with the information that we need to really understand and appreciate what the complaint is saying, not about time and such response, but also the detail that people invest their time to make a complaint. They do so because they're upset or they're worried or they haven't had their expectations fulfilled for whatever reason. And we explore and we investigate differently from PAS resolution to formal complaint process. I think go back to the metrics that Jude mentioned. It is really important for this board to understand the things that underpin those complaints. So you mentioned the things around clinical treatment and communication issues. So with communication issues, then we have a challenge around and an opportunity because I think we're on trajectory to do better than we thought we were around our information governance standards. And that's a requirement for the board to meet. So that is linked to not just some of the things that featured in communication, and we've had a discussion with the Council of Governors where we've talked about the additional needs of DDEF community patient service users. That's really important to maintain that look. But there are other patients who may project or describe a positive as well as a poor experience. A patient, younger people with neurodivergent needs, learning disabilities, complexities. Patients who have no communication at all. So I think it would be very interesting because that also addresses the health inequalities piece. How do we develop greater equity to make assumptions about who our patient is? Because our patient can be very, very diverse and very uniquely different, which is to be recognised and to be celebrated. But that sort of feature needs to come to be stipulated in the report that comes next time round to board. You can give that some consideration.
We can certainly do that and work with creating some because we get the if that's the focus, which I think is absolutely the right focus, then we can do with the assurance of performance at the quality QPS, and then they bring the so what bit of it to here in more detail, or we could just take as read some of the performance data and then get a conversation about. When we did have a really good patient story, which demonstrates some of the things that you're actually referring to there. So yeah, completely accept as much more. So we can bring this to life. And it is probably one of the most important things, isn't it? Yeah. You know, bringing the thing is the thing that patients are most able to articulate to us about the care that we give, because it's their experience.
Yeah, but also the positive aspect of that of that feedback, because we talk about patient engagement, we value that feedback, but it needs to feature more in our conversations, because going back to evidence base, we use that to form our evidence base, and we use that illustrate why this is important, why we're taking this particular action. In the same that we do for colleague experience. So when these things are happening, we're not collating what to do, really championing them, taking the opportunity to do so, then we're missing out. Really. So thank you very much for that, Julie. May I now request Faith to come and deliver the perinatal quality surveillance report and all this other detail. Apologies for being slightly delayed on the agenda.
Thank you. So the report has already been presented, as you'll see from the paper at the UPC on the 17th of February. But in line with the NHS requirements, I am here to present the headlines really and the highlights of the paper through to yourselves on board. So you'll see there's a number of areas that are detailed within the paper, and I particularly want to draw your attention to the report both on stillbirths and perinatal mortality. So both of these reports are a roundup of the previous 12 months, so end of December 2024. And in terms of highlights, there were 17 stillbirths in 2024, and that is the lowest number of stillbirths we've had in the previous 5 years. In terms of context, the national ambition set through Better Births was to have a rate of 2.6 per thousand stillbirths, and that was the national ambition, national agenda for maternity services. Within the NCA, our rolling 12-month period to the end of December was 2.73 per thousand, so not a million miles away from that national ambition. And if we think about where we were 2 years ago in terms of GM benchmarking and being an outlier, GM position was 4.41 per thousand over that 12-month period as well. There is a recognition across maternity services that that ambition of 2.6 per thousand was ambitious. And there are very few maternity providers, unfortunately, that will have hit that ambition. So there currently are discussions around LMNS benchmarking and giving individual ambitions to providers. And there's currently conversation that the ambition for the NCA for 2025 will be 4.0 per thousand, which is obviously more than we've achieved this year. So we have requested that that is reviewed. We would like to go lower than that. And we would very much still be working towards that national ambition, even if it doesn't exist at 2.6, because we believe that is a target that we can achieve at the NCA with the improvements that we've made. In terms of neonatal deaths, there were 15 neonatal deaths. And again, the national ambition was 1 per thousand. Within the NCA, we reached 1.41. So there's still some work to do around making sure that we are meeting and providing care in line with that ambition. I think there is a slight caveat to that we are obviously a tertiary referral area, and we do have a level 3 neonatal services, and many of those babies that died within our neonatal services were transfers in from other providers. But that doesn't mean that we still shouldn't strive to improve and meet that ambition. What we have identified in the reports, and you'll see through the reports, that although there continues to be care issues identified at external review, the harms that we are causing has decreased. So whilst there are still care issues identified in some of the reviews, it's felt that they had no impact on the outcome of the death or the stillbirth. So we need to continue to work to make sure that we aren't having care issues and that we continue to improve care. And when care issues are identified, even if they don't cause harm, there's appropriate action through our governance process to stop that reoccurring harm. In terms of workforce, you'll note that we signed off and agreed the retention policy at QPC. So this is a retention policy that's been written in collaboration with the LM&S. And the positive thing to note is that between October 24 and December 24, we had our lowest rate of leavers that we've had in the past 18 months. So we are starting to see some of that shift around improvements in retention, but also improvements in our recruitment and vacancy rate reducing. We've already mentioned at board today the outcome of our CNST review, and we have declared compliance with 10 out of 10 of the safety actions. Again, within the report, at the end of the report, you'll see the overview of the meeting, the assurance meeting that was carried out with the LM&S, and the feedback around the robust evidence that was submitted, and also a request that we work with NHS Resolution to talk about, as a provider, how we've used and implemented the 10 safety actions to actually improve safety, because there is a belief that sometimes it is perceived as a tick box exercise, and that should not be the case. It should be used to drive your safety improvement. So we were asked whether or not we would be happy to share some of our experiences nationally around how we've implemented the safety actions and how that has supported us to drive those improvements. I think finally, in terms of the Maternity Improvement Board, all recommendations have been completed following the niche review, and there is an opportunity for us to really take stock on and reflect on the work that's been done since we had that initial niche review. And it's just to inform the board that niche are going to be coming back in and re-auditing what we've said we've done, and that assurance process and that evidence is that external validation that we have met all of their recommendations, and that they are assured that the process that we have gone through as part of that Maternity Improvement Board implementation and oversight has got rigour and is robust. So that again will aid to that external validation of the work that's been done within the maternity services. I think finally, I've already mentioned reflection, and I think we've come such a long way in maternity services. And when you're in it, it's very easy to not remember all the positives that have occurred, because it just becomes part of what we do now. And that's good, because it is now business as usual. But I hope I'm not putting you on the spot, Tim, but Tim has come back into post as our maternity safety champion, and hasn't been in the service really for probably 18 months. And a couple of weeks ago came back as new back into post as our maternity safety champion, and had a walk around the unit and met colleagues. And I would just like you to hear some of Tim's reflections really on that walk around, because I think it is important that we all reflect on where we were and kind of where we are now, not forgetting that there's still work to be done.
Yeah, thanks, Faith. Yeah, I was going to mention that. I mean, Juliet, myself and Heather went round with you. It's kind of interesting because when this applies to everything. I think when you go to a monthly meeting or different things can feel like moving at a glacial pace. But I had last visited the service, I think, as you say, 18 months ago, and kind of there was a real palpable difference in the culture, the leadership, just the values that were being seen, in every part of the unit. So it was kind of an uplifting experience to see that, and the unit was on divert, I think, or about.
It was extremely busy.
And there was not any sense of stress, panic. I know there were, but I know a lot was going on, but it was very interesting to come back at that time. So, and similarly, the Maternity Improvement Board, I think that is a real example to us all of how to drive improvement. The other part of the safety champion role that's done in the past few weeks was on the perinatal patient experience group. And again, I've often asked the board, because it's not that visible, kind of the experience of mothers and families, but the enthusiasm and the engagement of that group is really interesting to see. So lots going on. And certainly the Maternity Neonatal Voices Partnership is far more embedded. It's a developing process than it was a year, 18 months ago. So all the result of real leadership attention and an improvement process that I think we need to kind of replicate in certain places. So yeah, I'm really looking forward to the next visit.
Thank you. And obviously those meetings and those walk-arounds are monthly, sometimes bi-monthly, depending on calendars and commitments. And as I've always said, the offer is open for anybody on the board who wants to come and look around, because I think it's really important that you come and you feel it. It's all very well me coming here and telling you what we're doing, but I don't think it's until you actually come into the unit and feel the culture and talk to colleagues that you're able to get your own assurance around what's happening.
Yeah, that's good. Litmus test even have. So Tim, your new name is litmus test. But of course, when I've been around, I can see that the conditions that was taking place, particularly around the cultural behaviours and the ownership of some of those problems. But it is a stark reminder of where we have been with maternity, and we're in a very difficult and challenging place. We're not saying that we are absolutely right, because it's great to hear that we're going to go back and have the colleagues coming again, do external review, that validation is required. We are a learning organisation, and that illustrates that. I would like to thank you, Faith, and also Annabelle Dye and Andrew, for your leadership in this area. It's been commendable how you've kept going, and there have been some very intense, significant difficulties that you've encountered, but your vision has been very clear. You have remained focused and evidence-based in the treatment that you have brought in. Feeling great. Count how many times I use evidence-based. Sorry, I need to divert. But again, it's going back to that acknowledgement and the fact that we are very much focused on the journey ahead and continuing with the need to improve. Just a couple of observations from myself, and that's relating to the. It's great to hear we have improved our recruitment, we've improved our retention, and we weren't there, were we, a few years ago? Absolutely weren't there. However, we do have the challenge around sickness absence in maternity, and that's something we mentioned earlier that just need to be addressed. It's a fragile environment actually to work in. It's very, very intense. And we know, don't we, that there was actually a shortage of midwives going into training and staying in the programme, actually. So the retention bit should not be understated. That's a real achievement. But I am concerned about the well-being of our colleagues, the rate of sickness. We just need to address that in a way that we will do positively and address some of those, maybe trying to understand what is it that is creating that as well. Other aspects of their life and experience that we don't know about. Guess we're not that one. The final point was around. I know that the Midwifery Council have introduced a new level of cultural skills, experience, and knowledge to address some of these disparity issues that we often talked about in the context of maternity. And we know, don't we, that some of our mums come from backgrounds in which there are some very negative assumptions about actually how they behave in relation to pain. But that competence, cultural competence that you mentioned, paper and we've talked about many times in community, I just think we just need to maintain a level of focus so that we understand that their experience and their experience of care and their experience of outcome is actually, what's the right word here? It's appropriate, and we understand the further learning we have to address to enable those mothers, from antenatal right through to postnatal, because we've talked about mental health earlier on. We need to talk about mental health with our mothers and their families. The final point around that is, in the report, you mentioned that there were a higher number, when you broke down from using the ethnicity lens, that there were a high number of mums from South Asian backgrounds who were in that cohort of neonatal death. I think we have to think about that. I know comparatively, when we do the comparison, it doesn't seem so acute, but actually that may be an emerging trend, because we were there at the beginning of this journey of maternity. So it's just always important to do the full loop and not lose sight of all of the credits we have achieved in moving forward. The challenge is retaining those credits and building on them. Like kind of a global picture. I feel the health, race and health observatory work that is done, and that's important. I'd love to see a feature about where that ended up and how that's impacted and made a difference. But also, how do we triangulate that with the niche recommendations that we completed? But maybe there are other areas when they do external validation that they pick up. We just have to have a state of preparedness to address them and make sure we pick them within our assurance and governance processes.
Yeah, I think in terms of the Race and Health Observatory, it's not only been a great piece of work in terms of the QI quality improvement process, but it's also increased the awareness of the team around, racism, and actually being able to talk about it more openly and more freely than maybe they have done before. I think also linked to the workforce element, Chair, is around us actively now recruiting people from diverse backgrounds to be able to be reflective of our population. So we've had some real successes, and I spoke to Juliet about this on our walk around. Some real successes with our recruitment of international midwives. So not only have we recruited on the programme that was set up by NHS England, we've also strengthened that by recruiting outside of that process. So there's an awful lot of midwives who are trained internationally that have gone through the process themselves, that have self-funded, have done the ROSCEs, have got their NMC registration. That's all been self-funded, and in other providers they've not been able to get jobs because they haven't got any experience of working in the UK. Whereas what we've done is we've recruited internationally trained midwives, and we're putting them through a bespoke support programme, almost like an enhanced preceptorship programme, to support them to be able to practice in the UK. And they're absolutely fantastic. And I think if you start to walk around maternity areas now, we are starting to see a much more diverse workforce that then contributes to that cultural awareness and that cultural competency. And alongside that, we are also teaching that on our mandatory training days now as well, because it's an area where we've got to have a real focus, because we know our population, 50% of our women are non-white British. We're not talking about a small number of women accessing our services. We are now talking equal provision. So that's what we've really got to focus on and continue to focus on for our demographic.
Just on the international, using that there before I forget, I did meet some of our international colleagues, and when they spoke to me about their experience, they actually, this links back to the wider determinant of health that affects the well-being of our colleagues, because the guest, but I think we should bring that in more focus. And they were saying they absolutely love working in the hospitals, they love everything about the hospital and the training, induction, all of those things. However, the housing in which they live is not compatible. Some of them are trying to move outside of it, some of them may leave. So that's another area of redress that we need to think about when we're having those well-being conversations with our colleagues. Thank you so much for the detail. Owen.
Thanks, Chair, and thanks, Vic. I think just a couple of things, Faith, and I think you would know that I know you understand this, but I think just want to make sure from a wider board perspective. So there's absolutely no doubt about the improvement journey that we're on, and when you look at some of the metrics that are on board, the kind of even better riff around some of this is, if you look at our staff survey, and it's great that we've had an increase. We've probably got the highest levels of response in the labour ward that we've had, certainly in my time being here. we're probably still not seeing the sort of breakthrough that we want to see in terms of how staff are feeling at that point of time in the staff survey. And then if you also look at the patient survey that we've got, and again, sort of uniqueness of our patient survey as it relates to how you described about the sort of ethnicity of the women that we can see, that plays out in the staff survey, so the patient survey. And again, that's an area where we would probably want to see some movement. So there's no doubt that we're moving in the right direction. You know, some of the key aspects that you need, clinical engagement and stuff like that, about some of the movement there. But I think I just wanted to centre us in, there are some other things that are on this journey, because it's a never-ending improvement journey, as you know. So I just wanted to just centre us in some of that reality as well. The other thing I would just point out, because Ted has joined us last week, as did Jude, on a conversation we were having with gynae colleagues, a 3-hour conversation that we were having. And although Faith didn't work with us just at the very, very beginning of some of the sort of 3 hours conversations, so again, for those people who don't know, reality plus response equals result. But Faith is kind of experiencing, watching a group of colleagues in the gynae world, perhaps being where we were in the maternity world, and some of the same people being in that world. So I guess what I'm just sort of highlighting to the board is, one, if you have an approach to improvement and it can work, it's important that we make sure that we replicate it and we do it. But in terms of hope and optimism about getting to where we need to be, you know, as Jude picked up and commented in the gynae conversation, even in the space of 2 months from an initial reality conversation to where we were seeing some movement in attitudes and where people were at. But you need improvement methodology, you need an approach in order to move it. You can't just expect things will happen by osmosis. But I'm just wanting to reflect that, and you know, I don't want to put you on the spot, but you know, you're kind of living these worlds now, aren't you? And I know that you've got some concerns and reservations about where we're going on gynae, which are important to have in this conversation as we work through. So I just want to put a little bit of perspective, certainly from my lens, about the even better if on some of this, but also how it kind of blends into other improvement work that we're doing. Thank you, Chair.
Yeah, and that actually is a reminder to me to look on the wall behind you, right hand side. There will be colleagues coming from the quality improvement team down to university to talk about what they're doing, what they put in place, and why it's invaluable. It's an invaluable tool. You can't talk about reducing patient harm unless you have a methodology to work through around it, how we deliver improvement and how we make our care services safer for our patients and also safer working environment for our colleagues. So when you have time after lunch, please do stay behind for that conversation. The marketplace we're going to be holding. I am diverting quite a lot, not keeping control of me. Going after me. Okay. So, Faith, can I thank you very much for your delivery review. So, congratulate you on what you have done. So, it's been a heavy, consolidated journey, hasn't it? There's been ups and downs, but you stood firm with your leadership. So, on behalf of the board, can we thank you very much? And of course, Andrew and Annabelle, yeah, and the wider team too. And continue, and we'll support you going forward with that emphasis and focus that you have given relentlessly to how we do deliver on improvements, going back to Tony's point. But ultimately, we have to deliver on patient experience and community outcomes, actually, which is where we're heading. So thank you very much indeed.
Thank you, Chair, and I am optimistic.
Yeah, hopefully the wonderful vote.
Thank you.
Thank you. Thank you so much. So colleagues, can we move then on to my next patient policy? So Chris has already said it's going to see, it's been discussed in depth. you are mindful and recommending to the board that we endorse the policy. However, as the board, we need to review further, take any questions or any points of clarification. I have a couple of comments as you would expect. Is there anything that colleagues would like to mention? 6, that's Jude.
Yeah, thank you. I'll quick and catch us up a little bit. So this has been through QPC, it's been through SMT. It has been the subject of a weekly task and finish group with significant clinical attendance actually at it. Is chaired by either Heather or I. It's important to say that this is just part of the journey on my next patient, and whilst we are live in Bury and Oldham, we have gone live at a time when we are flipping between full capacity protocol, and so that's teaching us some things as well about where are the lines between my next patient at full capacity protocol that signals we have to do something else, and that risk appetite in the organisation is lowered considerably in order to manage the totality of the risk. So I think this is important to say that we need to continue to report this through Q&P monthly about what we're finding and learning as we go along. We've agreed that we continue the task and finish group weekly. We've got a series of feedback loops about actually, is this policy actually workable in practice? Because it has got a far greater number of controls around it and that are written into it than we had previously. And that may become unworkable if I'm just straightforward about it. So I think that continued review of what we're doing is important, and there's a number of ways in which we're going to do that. So feedback about the process through that staff engagement, incidents and complaints that come forward, picking it up through our daily UEC huddles that happen. And I think from our site bed managers through local sit reps and through our staff and patient experience teams. We've also got fire officers who are doing walkarounds and ensuring compliance with those temporary escalation spaces. But fair to say, you know, in the first few weeks, we've identified, and it's the interaction of one policy with another, really, which you write a policy in good faith and then you operate it in practice inside your full capacity protocol, and it starts to eliminate some things for you. So I think what we're presenting here is what we are live with, that it meets the requirements that were set out for us in the Regulation 29A, whether it continues to be workable for us, and actually we can have a policy that is my next patient and it can sit in harmony alongside the full capacity protocol, and it actually is impactful in terms of overcome the risks that we're carrying in overcrowded EDs. I think still remains to be worked through by the teams, and I'll stop there.
Thank you, Jude. Are there any other comments? Yes, Jude. Oh, Katie.
Yeah, thank you. So Jude knows what I'm going to pull through because it's the conversation we had at SMT, but I think worth repeating here because for board colleagues, there's a real importance for us. I think we shouldn't miss it between the My Next Patient, the policy and the work around it, and our internal professional standards, which were launched as part of the response to the Regulation 29. Because one of those key elements was how colleagues from different areas interacted with each other, how they behaved, how they held those standards. And I think it would be really helpful in those reviews going through QPC to also bring in the development of the internal professional standards. And I know from the discussion at SMT that we're tweaking them to reflect some of the GERF standards, but it's for me not necessarily the content of the standards, it's the matter that we have standards and that colleagues adhere to them and follow them. I mean, you know, to quote the song, it's not what you do, it's the way that you do it. So I think behaviours are really important in this. particularly in a time of, you know, high pressure winter, etc. So I think it's just that there's a real connectivity with our internal professional standards here. That would be good to see going back through QPC.
Thank you, Chris. That's what's really wrong there. I absolutely agree with it. Chris.
Thanks. Two things really. Firstly, what I was trying to do when rereading the paper here was imagine what it's actually like in practice to. I think I came to the same conclusion to you. It might be quite difficult in practice to, when things are happening, to go through these stages. So I think your approach of continuous monitoring and evaluations is a good one. I'm not sure how much adaptability there was in the process, but I think that's hard to judge. But the sort of broad point, I suppose, was the table that you've included with the 1, 2, 3, 4, 5 PQC queries. I mean, there's a response there. Are we happy that that meets the question? Do we know any? Have we any intelligence from the CQC whether it meets the question or not?
Yes, so we shared the information with the CQC on paper. You know, they've asked us some things, we provided a response. The proof in the pudding is they will come, Chris, so they will come and test out in practice is the theory that is described here. This is what we're doing. How, and this is where I think we came unstuck before, where actually the theory in practice, they don't quite see it happening. So they will come back and take a look, and I think they will only be satisfied when they have taken a look and said, actually, the things that you've said, the things that you've written down in your policy, your adherence to your risk assessments, your process controls, we can see them work in practice. I think the issue for us is how much effort is that taking us versus the gains that we are getting from it. And, you know, when our nursing staff are highly pressured, you know, is the gain of those temporary escalation spaces versus all of the work that they need to do to ensure that we remain within the controls of the policy and the documentation on balance is that worth pursuing, and it's back to the effectiveness and the cost effectiveness, because actually people's time to manage a process, it counts, you know, because it is capacity that is being utilised. So I think really that's the nub of this for me. Is it giving us enough gain for the effort that it might take the clinical staff to manage the process?
All the staff said.
And I think that's where it starts to come out as we go through. It isn't too hard.
Thank you again. It's really well made. I think Owen and then Julie next.
Yeah, I think a couple of points to make. I think one, looking back a little bit to the example that was demonstrated by going to look at maternity, I think this is one where I think no board member should just rely on what comes to a board report on this. And I think not necessarily all at the same time, but I think seeking visual assurance, to Chris's point, where our colleagues on this, to be asking the colleagues themselves, but also not just willy-nilly on that. If we get feedback, it goes into the loop that Jude and Heather are chairing in terms of that becomes important. So I would really urge board colleagues over the coming weeks and months to just to their own board of assurance by actually taking a bit of a look and speaking to colleagues and getting that temperature change. I think the other point I would say is that this work, if we recall, did come out of a CQC inspection of particularly older medicine, and Some of that was born out of freedom to speak up, concerns that linked to continuous flow, although not exclusively about continuous flow. I think it will be just worth reminding ourselves that any time now there should be publication of that CQC report, because we actually haven't had that yet. So I just wanted to put that on the board radar, that at some point there will be a CQC report that will give us flavour of where we're going, and that, if my understanding of the timelines is right, that should be being published anytime over the next week or so. So as soon as we have that report, I think it'll be important that the board gets an opportunity to see that, or more importantly, QPC probably gets an opportunity to see that and comment on it, because that might, in terms of what it shows us, might give us an interesting perspective.
Thank you. Julie?
I'll just following the point about GDC, I'll go my original point. So, we are arranging to speak with CQC, our local CQC inspector next week. We have submitted our feedback on their draft. We haven't received back my knowledge today. So then we will be setting up for an informal walk around towards the end of March, where no doubt we will be going to look at this. I think if you take it back to what this sort of policy is designed to do, what practice is designed to change, this is about getting all of our teams accountable for patients that are their specialty, that are in ED waiting for bed. So it is about keeping that flow right. So if we get this right, and we've done a lot of engagement with the relevant clinical colleagues who understand why we would want to do this. It's not something that would happen when you've got full capacity. You different out over there. This is about thing. For our patients waiting in ED, we need your specialist skills. Can we get them there? So, I think it's to be reminded of the safety thing. We're trying to do two things out. We're trying to keep ED safe, but we're also trying to get the right patient to the right place. And I think it's up to us to make sure that we implement this policy with that aim in mind, as well as reducing pressure in ED. If you're a patient who needs a respiratory service to support your needs, then you need to be there. So I think just that, my observation coming in was, it's a great policy for dealing with that safety issue, and it also helps. That's the flow issue we're trying to fix here, not I do think there's a lot of work still to do, but I think it's the right behaviour we need to engender within our, whilst they still can feel safe to say no, it's not that, it's that they recognise that their patient is actually an ED waiting.
And that actually, your point there really contextualises where this conversation needs to embed itself. So it is around safety care, it is around quality of care, it is around flow. The reminder that why we started this in the first place, it was on the back of the Section 29 CQC concerns, and they were serious concerns, and we paused the flow model, remember. And so this is not my experience isn't a solution to that. It's much wider. So Gertie's reminder also of the professional standards. We really need to feel comfortable and confident that our colleagues own the patient, because when they're in temporary excavating places, as was identified on the CQC reports, there were elements of unsafe care. There was poor observation. So we're doing all the right things, but we need to connect them in the right way, and that's very, very, very important. And I think we should do the walkabouts and have the opportunity to do so. I think colleagues are very mindful of that. It's understanding when and when to go, because you don't want to disrupt colleagues' time. So if we can organise that as an action, that would be really helpful. I know it's never ever a right time, but we absolutely need to do that more. Thank you very much. Oh, Owen, do you want to come back?
Yeah, just a reminder, and it's probably an offline thought, Jude, about being able to just understand how this is progressing, perhaps with the contrast between core hours and out of core hours. I think it's important that when we're assessing this, we don't just aggregate everything up. I think it'd be just good to know what that's looking like. And again, regarding the sort of visual audits, I'd also suggest to you, Chair, that whilst it's good to have planned audits on that, colleagues shouldn't be fearful about having perhaps just unplanned, to do with the facility, drop-in conversations, because they're just as valuable as things what we might do in a planned sense as well.
Yeah, the combination of both, absolutely. If I went into the Panda unit, and that was unplanned, but I needed to know who to speak to and find who to speak to, and with young children, babies, it's going to be difficult. It's how we do that and support each other to do so. Points really well made, thank you. So going back to the recommendations in terms of my next patient policy, we are asked to support the decision made for go live of my next patient model in February. We looked at phase rollout plan. We recognise and acknowledge Jude's points around the fragility of this, the fact that we need to review and maintain a robust review of what we are hearing, what we're seeing, and what patients are experiencing ultimately, but also that we haven't had the feedback from CQC that in sharing the policy with them that they have found it relevant or whatever. We don't know what their position is, so it's really important we have that as and when it comes due if possible. So reviewing is constant, something that is not just saying that and yes, we are reviewing for the right reasons. On that basis, colleagues, can we accept the implementation as it is, as it sits at the moment, of the My Next Patient policy?
Great.
Thank you. Okay, thank you very much. We'll move then on to, I know there's a short break here, so if colleagues would like to pop out, please do so, but if it's okay, can we continue? Would you like a break? Continue. Right, thank you very much. That leads us on then to the spinal patient safety update report, please.
Thank you, Chair. Colleagues, this pertains to the historical spinal issues that we had in what used to be Solomon Royal Foundation Trust and now NCA. And this is a very brief update paper just to bring colleagues up to date in terms of what's happening at a high level in April. So our next board meeting will bring a very detailed report with all actions under each of the action points. So as a reminder, there are essentially 3 pieces of work that are described here. The first one being the spinal patient safety look-back review, which board saw in 2023. Out of that review, which looked mainly at the patient harms that resulted from the practices covered in the terms of reference, there was a series of actions that came out of that that have been implemented in the trust and have been overseen by Salford Salford Care Organisation, essentially through the governance systems. And within that, there were a total of 16 actions, of which 12 have been completed and 14 are pending. And we're expecting them. I'm sorry, there was 6. I'm being corrected by Julie. I apologise. There were 16 actions, of which 12 are complete and 4 are pending. The 4 pending actions we're expecting to close in April. There's one action that might take a little bit longer than that, and we will bring that detail to you next time. The second piece of work is essentially the Green Report, which looked at the culture and practices within the trust during that period of time to identify essentially lessons learned to ensure that we don't end up in the same place again. And that report was seen by board in 2024. And there were 6 recommendations that came from that report, which were translated into 25 actions in the action plan that we're working on. Of those 25 actions, yes, there are 9 outstanding now. And again, we will bring you the full detail of those actions and when they will be closed. We're expecting most of them to be closed by April. There is one action related to what we do around DATEX, medium to long term, with the potential consideration of a future system, which will take us a little bit longer. When the 2 reports were published, we invited anybody who was impacted, who hadn't been seen by the services, to come forward. And there's a total of 39 patients who have come forward wanting their care to be reviewed. And that's the third piece of work that's described here, where essentially an extension of the look back review is being done for those 39 patients. And the report describes essentially what we're doing with those. They're going through a very similar process to what happened with the spinal patient safety look back, and 22 of those patients have had their completed reviews and heard their outcomes. And there are 17 patients who are essentially within the review process. Within those 17s, there are some challenges because there are some notes that aren't accessible, some notes that are limited, but we will work through those. And again, we're expecting that to be done in a timely fashion. In parallel, the chair has met with the patient group, or patient group representatives in this room. Actually, we had some really constructive discussions. Through those discussions, there are just a few things that are emerging that we will need to address related to how the patient family's voice is being heard in this process. I think the process from a sort of clinical review perspective is quite robust, but patients feel a little bit distant and excluded. And there's a few other things about how we can support them that we need to work on. And we have agreed with them that we will go meet with them in their own space, the patient group, again, to extend those conversations. You'll also be aware that there is some media interest in this. And so every now and then this is profiled in the media. And there's been some political interest with MPs being involved, and Under Secretary of State as well, sort of weighing in specifically on the question that the board has considered a few times, which is, should we do any further review of patients, or do we think what we've done is satisfactory? Our position has been that we will cooperate with whatever is decided by colleagues in NHS England, national, in collaboration with government representatives. And so we will stand by that, and we will wait to hear what any further suggestions or decisions are around that. With that, I think that's sort of a quick summary of where we are, and happy to take any questions.
That's great. Thank you so much. Do you have any follow-up?
I just wanted to make 2 points just for clarity. Sorry. 2 points just for clarity. One is that the Carl Reid made 6 recommendations in his report. Then last May, the Green Recommendations Oversight Group, they set 25 actions that related to his recommendations. I just want to be clear on that, because there's a little bit of confusion about, is it the 6, is it more? And actually over time we have added a few more actions to that list as well, when we've kind of gone through the process, and we had a discussion yesterday about actually should that be a few more to break those things down. And the other thing was the 39 patients that came forward, they are people who came forward after the spinal look back review and Green report. So it was both. So it's basically over a 2-year period we have those 39 people. So I just wanted to clarify.
Thank you.
Thank you, Julie. Are there any questions still we have?
I think just a couple of things, just to confirm that of those patients that you talk about just now, Julie, not all patients were really patients who were receiving care by the consultant in question. I think that's important contextually around some of that. I think it's also worth just mimicking that one of the recommendations from the original services look back review was about making a referral to GMC. That referral was made pretty soon thereafter in 2023. I think it's just worth noting, Chair, that we're still awaiting the outcome of that GMC process. Thank you, Chair.
Thank you very much for that. Good, and then Jeff.
Yeah, I think important for us just to keep reminding ourselves that there are some process things here that we've described, but there's also a bit about the effectiveness of our systems currently as a result of some of the processes that we've put in place. And actually, are we keeping patients safer today than we were historically. So notwithstanding the kind of cultural aspects, there is an important element about the multidisciplinary team meeting in spines here that is central to some of the ongoing safety and decision making. And Chris will know, in complex surgery, the effectiveness of those multidisciplinary teams, the contribution, the planning, the decision making, the documentation, the governance of it is really important. So I think there is an important action that is contained within the plan, which is about assessing the effectiveness of the MDT as it is today. And I think we shouldn't lose sight of that, in that it's an action that's closed or open, but that actually, what's that telling us that has changed?
Yeah, and that's a really good point, because actually that came up in the patient engagement group. They want to know what the limit has been embedded. What have we done thus far to embed and improve the circumstances of patients who've got very complex spinal issues? And does the MDT function well? And maybe we will that effectiveness piece into the report in April, if that's possible. That would be very helpful. Thank you. Jeff.
Thanks, Jeff. The agreed recommendations oversight group met yesterday, chaired by Rafik. On the basis of the discussions of that meeting, I would like to request a further meeting of that group before the report is compiled to come back to this board. I think there is significant decisions made on the recommendations from pre-relations governance and on HR. And I think the oversight group needs to see further progress before it's reported here. I think mentioned the issue of communication and engagement of the patients and their families, and we endorse that. And I just mentioned for clarity, there is a resource implication there in terms of executive capacity to support that process, which I think is quite urgent. And we welcome taking comments, picking that up.
Yeah, again, really helpful. Jeff, I think that should absolutely happen, because it allows another layer of oversight and also a reflective opportunity actually to think through whether we've covered off all of the things that we are known to us on the request of our patient group, but also our colleagues.
Do you mean a bit about an additional meeting?
Yes. Yes. Yeah, I think that's absolutely right. And just going back to the resource element, we also identified that from the patient engagement meeting that we had, particularly around the support and accessibility and timeliness of the review and follow-up. They were featured with. Thank you. Right, so on that basis, can we? Oh, sorry. Oh, sorry, I was looking at this.
Sorry. I'm going to be a governance owner, but I just want to be really clear about reporting of this, because in the advice section here it says action plans progress but being overseen by quality performance committee, green recommendations oversight group, and safety summit and so on. And there are three things. I think it's really important just be dead clear who those things are related to, so that when I'm sitting at QPC, I'm not straying into things which have been looked at somewhere else, or if I should be straying into, I'm dealing with it. And I just think at the moment that's not as clear as it might be here. I'm sure it's clear in the actuality of it. It's not as clear as it is here.
Yeah, that's a really helpful point. And it's that kind of focus that we need to bring back and think carefully about what the ask is and how it's going to be delivered and in what format, and who's going to take responsibility for it, leadership governance position. So on that basis, can we extend the Rafik.
Yeah, well, I'm just making a note. I'll come back on that point, but I was going to wait.
Yeah, just on the MDT point, I think it might be advantageous to others not to just focus on the MDT point, but to focus on, so if there are some people, for example, with a mindset that feel not being sufficient change, or there hasn't been change, I think this is just a perfect opportunity for GERD, actually. And a perfect opportunity for an external process which is inclusive of colleagues, where factors like the efficacy of the multidisciplinary part can be looked at, get an external view on it, and certainly hopefully with the board blessing, if I can be tasked with seeing how that could be created and developed as part of this process, I would be happy to take that.
I'm sure that we give our blessings to to take that.
That's essentially an external
really helpful.
advice
Yeah.
of them.
Yeah.
But not just solely on the MDT. What their review would have been typically to come and have a look at that piece of work. If whether it be our own colleagues or whether it be service users, patients, whatever else, if there's doubts that still remain, why wouldn't we follow what we've done before and get somebody to come and have a look on that independently and do that?
Yeah, because that also will address the concerns raised by staff bodies.
Yeah.
That would be very important as a teacher. Thank you, Erin.
Thank you, Chair, and thanks everybody for the input. I think some really good points. The reporting one I'll tackle first. The essentially the patient reviews, 39 patients, which means stop calling 39 patients, but that cohort of patients that we need to look after, that should absolutely report into QPC. The overall green action plan goes to the green oversight group. So we need to make sure that goes through QPC, and I'm happy to ensure that that's the case. Chris, 5 of those patients, just to be clear, because a comment was made, 5 of those patients, when we looked at them, had not been looked after by the spinal surgeon in question, but we have looked at their care nonetheless, because they've come forward. The resource question in terms of ensuring that the single point of contact and the patients have that sort of connectivity was raised and discussed at length yesterday. Juliet, myself, and Heather will work on this to make sure that we get this to the right place. The MDT meetings, that's a live conversation. We're actually in discussions also with NHS England specifically about ensuring that we have analysed MDT, and they're helping us with that. They come to see the separate MDTs, and we have some follow-up discussions with them to bring them together. I think I have one question just about an additional meeting. Given we're planning to bring it forward in April, I'm just a bit concerned about the logistics of squeezing in an additional meeting in the next 4 weeks, keeping in mind that we would be submitting work papers, just looking for something like that. So just a little bit worried about those logistics, but happy to take a steer from the board as to whether we bring all that detail for a discussion here and then follow up in another pre-meeting, or do we want one?
I think if we can accommodate just requests, it will be helpful. Just because it gives them an opportunity to consider that. But if there's complexity, we can put together.
We'll do it. I'm slightly worried about logistics just in time. But very happy to.
You should bear in mind that there are patients and representatives on the website group, and I don't think I'm alone in being a bit concerned about the progress being made, and therefore I personally want to have a quick meeting just to get a more complete report as the website group. I think Chris makes a good point. As a member of the website group, I'm not seeing the full picture. There are references to issues being dealt with by reports to the Personnel and Education Committee, Policy Committee, which I should go find, I suppose, but I'm not getting at those meetings the full picture. I understand they're important, it's all wrapped up in report here. I've just found that oversight to do its job. And whilst I think getting right first time would be an excellent idea, there's a board responsibility to understand what's this organisation done to make this better since we received the green reports. And by all means, from that point, move on with a really tough getting right first review. But I don't think we're there yet as a board of understanding what's this organisation done to respond to that report, but part of it and make it better.
Yeah, no, that's right. It actually reflects the terms of reference for your involvement in the.
Thank you.
Thank you very much.
Thank you.
Thank you. Okay, we'll move on then to people education. Aziz, please.
Thank you, Chair. We met on the 22nd of January and 27th of February. This is a sort of, we've all read the report, so I'm just going to summarise. For assurance, we were pleased that feedback from the Accelerated Leadership Development Programme showed 94% satisfaction among candidates. We were also pleased that in the quarterly patients report that the feedback on I was treated with kindness, compassion, dignity and respect increased from 93% to 96%, which we think is amazing given all the pressures we know all our staff are under and should be commended. We had an update from Rochdale Care Organisation and praised them for achieving 93% my time, that's annual appraisal compliance, which is above the 90% target, one of the few areas above the 90% target. So alerts, we talked about sickness earlier. Obviously, that was a major issue we discussed. As Gertie said earlier, it showed a steady increase for the last year, 6.61% annualised, 7.71% in month in January. And the actions to address this include reviewing the top reasons for absence of both short-term and long-term absence to identify support that we can offer colleagues to maintain good health, focus on welcome back conversations, the return to work to support short-term absence reduction. And when I was talking about a step change is needed, I'm actually supporting you, Gertie, in this. I know this, we have produced this. However, the compliance to this is 20% in many areas. It is simply not good enough. So we need a step change in the return to work conversations. That is when you will hear why the person is away, what support they might need in coming back, you know, and whether we can put that support in place. And some of these conversations I know are being had, but it's not being recorded. But we need to record it. We need to have evidence this is being done, so our staff are spoken to when they come back sick, so we know if they're okay to return to work. And another alert was my time compliance in the organisation, still below 90%. Again, if we get this above 90%, it's about the opportunity for that a well-being conversation, not just a performance conversation with all of our staff. The other alert was the number of employee relation cases involving Black and minority ethnic colleagues remains proportionately above those in our NCA population. It continues to be the case, even though it has reduced over the year, but it is still well above the NCA population. So work is taking place with the EI team to review the just culture process, providing further training to teams, and this forms part of an action plan to reduce the number of ER cases and length of time overall, actually for all ER cases. And for advice, we had an early insight report into the National Staff Survey. This is embargoed, so I can't give you any details of it. However, it's in the reading room of the People and Education Committee, and it makes very interesting reading, and I would recommend that you all take a look. Following the recent audit of equity, equality and inclusion undertaken by the internal auditor, it returned a limited assurance outcome, and there are actions to be taken, and these will be reviewed by the People and Education Committee. Thank you.
Thank you, Steve, for a very comprehensive update and concise. Are there any comments or questions? Gertie, do you have any follow-up?
No, I think Aziz has covered everything that was there. And we do have a number of additional reports as well on EEI today. So thank you, Chair.
Yeah, thank you. And I think some of the information in the reading room will feed into the paper we're going to talk about bias and aggression.
And just so everyone, I mean, as chair of the People Committee, I have read all those reports in full.
Colleagues, any further comments? No. Can we that we have noted and received the report from QPC? Can we move to matters of escalation, the equality, diversity and inclusion annual report? Gertie?
Thank you, Chair. I'll try to keep this brief because I am mindful we have gone through some of this already. So the annual report is here for colleagues at board to receive and note. It has been received and approved at the People and Education Committee this month. We are required to publish this report by the 31st of March this year. It is the annual report, and board members will have received this over the years previously, setting out the demographics, the breakdown, the characteristics of our colleagues, along with other areas such as flexible working, access to training that is non-mandatory, pay gaps, etc. It sets out our equality objectives and the embedding equity approach we have. We also look at patient and colleague data, and I think it would be remiss of me not to say that what it does show in terms of the patient and colleague data is that there is still a significant amount of work for us to do to improve the experience of our patients and our colleagues, and there is a clear need for us to do better. We have action plans, we are doing a lot of work around that, but it continues to be an area that we need to relentlessly focus on. I would like to take a note for the annual report to commend Jess Zadig and her team. Who've put a huge amount of work into a report, and I remind colleagues that Jess hasn't been with our organisation for a year yet, and yet has produced a number of really good reports for us today. I'll leave it at that in terms of my summary, Chair, but happy to take any questions.
Thank you very much, Katie. Are there any questions or comments? Absolutely, on behalf of the board, to acknowledge Jess and so the colleagues team in presenting this information, both for the Equality, Diversity and Inclusion report, but the gender pay gap report that comes later. Yes, please.
There was something I would like clarification on. So in that EEI report, which I said I read in the reading room, the EEI objectives are not in that report. It says they're under review and yet to be agreed by board. And I wasn't sure when, I couldn't remember if we discussed when this was scheduled to happen and when we're going to. So we kind of need to, because it's a blank, it's red, it's in red in that report. So.
Off the top of my head, Aziz, I can't quite remember. I think it usually comes in about June time, but if we could take an action for me to confirm that and then update colleagues outside of this forum.
Yeah, no, that'd be really helpful. Can I just address on the appendix A? So item number 9, Alex has put a point around health and equality piece. We mentioned that earlier on, didn't we? But that's the blank there. There's no information or data in that. And then that 10, the positive behaviour action plan. I'm just wondering whether we have extended that. Are we also looking at trainee experience and medical students and other?
Yes, I can confirm the positive behaviours applies to colleagues, students, temporary staff, contractors, etc.
And then, Alex, do the other people on health inequalities and emergency care?
If I can take that as an
it's a gap, yeah. So just all right. Thank you very much. So. Colin, can we agree we accept the reports and notes and also acknowledge Aziz's very comprehensive report there, Gertie's comments and updates. Gender gap pay gap report, please. Gender item 13, Gertie.
Thank you, Chair. So again, we are an annual report that meets our duties under the Public Sector Duty and the Equality Act 2010. We received in People and Education received in June 24, and then the final report in February this month. Again, this is a report that will be published on our website by the 31st of March. So gender pay, it is a snapshot of the position the organisation was in as at the 31st of March 2024. It measures the difference in average earnings between men and women, which is markedly different between the issue of equal pay, which is the principle that should receive equal pay for work of equal value. What we can see is there continues to be a gap between the average earnings and median earnings of men and women in the Northern Care Organisation. It has improved slightly in year, moving from 25.7 to 23.4. One of the primary areas where we see greatest differential is the area of bonus pay, which is I'll pull out for colleagues. And bonus pay is not sort of something we have a lot of in the NHS. In fact, the only bonus pay is clinical excellence awards for medical colleagues, and if there are legacy discretionary awards for what would have been staff grades and their SAS doctors. We have seen a national review of clinical excellence awards, and the gender pay variance nationally has been identified. Clinical excellence awards have now been agreed in last year's finalisation of the industrial action. They're going to be mainlined into basic pay. So it will be an item that we will continue to see from a legacy perspective. However, they're not available anymore. I'll leave it at that in terms of that. There are a number of areas which, again, Jess has highlighted she would like to do additional review, particularly around medical and dental pay, bonus pay, and then some additional areas. And again, take an opportunity to commend Jess for some really good work and a very detailed and comprehensive report. Thank you, Chair.
Yeah, and we share that conversation to Jess. Really excellent report, very interesting. And I think there's many opportunities there for us to leverage some of those findings to develop some of our leaders, particularly our women, in going into leadership roles, but also extending their competency and their ability to achieve slightly more in terms of bonuses. At the moment, our men are certainly overperforming in that place. And something also, we should remind ourselves that we are an education and training institute. We have lots of academics and we have dual roles, and sometimes that also skews some of the percentage of the data that we see. Go through it for further reiterations another day. Are there any other comments from colleagues? Yeah, Maria, thank you.
So it's good to see the movement between the years, but if the minimum is ending to gender parity and we move 2%, I guess that says it's going to take us quite a while to get to that. I was just wondering what's our ambition and where do we want to get to and when? Do we have view of that? I've not seen what the targets are around gender parity and when do we think we can get to that? Do you have view of that?
So I think there's some complexity in terms of the limitations of us with a national pay award and national pay scales. So if I think particularly of the issues of the only bonus scheme we have is clinical excellence awards and or discretionary awards. That's now a matter that's no longer within the live pay for medical colleagues. So we will continue to hold those awards that have been historically awarded, but we will not be able to influence or change that because it's going to be added into basic pay. There is continuing work. I'm not sure we've set a target particularly, Myriad, and that's something I will follow up with the team in terms of what our ambitions are in terms of movement. I think it would probably be something we would need to do once Jess has done that further work she's proposing in the report, to then understand where are the areas we feel we can influence and to what degree. So I think it would probably have to be something once we've done the deep dive we would have to come back to you on.
I think it'd be good that we are clear where we want to head to and how we get there.
Absolutely.
It'll take us quite a while with people. And I think for me, even if the pay is dictated somewhere, it's how we apply it in our organisation. Because if people are doing the same role, then my ambition in my head is that they'll be getting the same thing, regardless of how much is coming to us. So worth just understanding where we want to go and kind of our plan to get there.
Thank you for the points.
It's a good one to say. I think the clinically led model might give us an opportunity to maybe make some inroads in this. So we should bear that in mind as we move forward.
Thank you. So can you stay with you now?
Yes, thank you, Chair. So again, I'll try and be brief. So EDS 22 was the updated equality delivery system, and we received and approved this report at the People and Education Committee in February. And again, this supports us to meet our requirements under the public sector equality duty and the evidence that we've set out. So there are three key domains that EDS 22 considers, which is commissioned and provided services, workforce health and wellbeing, and inclusive leadership. We agreed as a board in last year that the areas we would focus on were maternity improvement, D-Death services, and the front runner programme in terms of domain 2 for health and wellbeing. That was the SCARP health and wellbeing programme, in particular men's and women's health, and some additional information in from the Occupational Health Department. And under Domain 3, with the areas that were considered were the Advanced Leadership Development Programme, the Anti-Racist Framework, Population Health and Health Inequality Board updates. I note for the board that in all areas we have scored as developing, and just for clarity for the board, that the scoring is undertaken by a wider multidisciplinary team where colleagues come together and agree the position we're at. That score will be an area that we continue to develop and work forward, and I would hope when we come back next year to have seen that improve and move. So in terms of the areas of focus for 25-26, it would be for Domain 1 with maternity services, cancer services and right care, right person. The demographic detail for colleagues accessing health and wellbeing, so that we can then look to ensure that that's equitable access and that people across all areas are accessing it and improving that, and board and senior leader commitments. Again, I think I'll leave it as that, Chair, but happy to take any questions.
Thank you, Katie. It's a really concise summary. Are there any questions or comments? I think the focus next year is really good. I'm pleased that you're retaining the emphasis on right care, right person, and give that those impact on our appropriate and timely care issues of our system in order to improve that. So we note the developing stage. I think that's fine because we need to get to stop where we are. But we seek to develop further, don't we? So we look forward to the next research. Thank you very much. Good. Carmen, sorry, you next. Research and innovation, please.
Yes, thank you. So a report from the February committee, some really great news, and I'll start with the positives. We had a really insightful presentation about the Geoffrey Jefferson Brain Research Centre, or the GEF as it's known. Sure you'll remember that, Jeff, over there. And Andy King came along and presented the annual report, which was really, really great to hear about, and I did feedback that it's a really easy to read written report. There are some medical terms in there that I had to Google when I was reading it, but other than that, it's a really, really positive report, and I would encourage anybody to read it, and it's externally facing. And I have asked that we have a bit of an update on it when we have our board development session on the research actions and research strategy. And although Andy is really, really keen to come and do that himself, we've already got some guys coming to do that, so they'll represent him. We also had some great news about Claire Howard, who was an orthoptist who has been awarded Advanced Clinical Practitioner Academic Fellowship and just under £775,000 worth of funding for a 5-year project, which would start in April, which is fantastic news, really, really great news. So we'll track how she's doing with that project. I'm not going to go through every single thing that's in the advice area because I know you will have read it. I wanted to highlight a few of the alerts. So we've had previously reported from other R&I committee meetings that the guys in the research space have highlighted their concerns about how much space they have to continue to do more research, and there are challenges about the CRF footprint. And some discussion has taken place with the estates team, and there have been a visit conducted to the area to understand what the challenges are, and a follow-up meeting is scheduled for this month. And I'm flagging that because I don't want it to be yet another item that takes 12 months for us to get an action moving on. So I'm hoping that we'll get some follow-up on that pretty quickly. And I know there are competing demands on our estate, so they can't assume that they'll be top of the list, but that's something I think the board needs to be aware of. On our digital strategy, we had a good discussion on the data centre server estate and cause for concern and how many servers we have that are unsupported, and that's in the alert section. And there are a number of other items in the alert section which I think it's important that the board takes note of. We did discuss earlier about a transferred risk, about the coding backlog, and that's here listed under the R&I committee, and we've agreed we'll transfer attention on that to the P&E committee. Thank you.
Thank you very much, Carmen. Very concise and insightful update. And again, we acknowledge the alerts that you have raised. I might ask Lorna if she can some further comments against those. But to celebrate the work of the Research and Innovation Committee, you lose sight, don't you, sometimes of the fantastic work that goes on in the organisation. And efficiency isn't just about funding that we seek to come to the organisations. Efficiency through innovation, through embedding some of the learning and the research outputs that come in, and the fact that they receive this massive grant, Claire's received, again, can't understate that, but it's very competitive in research. These don't come easy, so it must have been a very robust research proposal to make that happen. But the fact that the innovation in itself is a cost benefit, it's important to acknowledge. I feel you made this point really well, Carmen. Just around the digital strategy update, Lorna, would you like to give some further insights on that?
Yeah, so I think it's right that it sits in an alert, but I also think there is some positives to be taken. The update that we provided is in line with the digital strategy we've defined, which, if colleagues will recall, is very much about getting the right foundations and the baseline in place. We spent quite a lot of time now in discovery in many areas in digital, getting a much clearer understanding and picture of where we are and what we have. And I think to be able to progress forward, you need that clarity of understanding. We are now in a place that we are much clearer on what that fabric of the estate looks like. We do have a significant size of data centres, 1,900 virtual servers, even for what is 26,500 user accounts in this environment, is sizable. It is substantial. That exceeds some of the banks that I'm aware of, who are dealing with millions of customers every day. So there is something wrong in terms of proportion about our overarching size. Because of previous investments we've done, and we are very much NHS drives you to do capital investment, our acquisition and capital spend on servers has been quite regular in history. The last seismic investment that was done was Salford Royal and Pennine Care. So you're talking 6, 7 and 8 years ago that heavy investments done on infrastructure, and very much little since then. So it's no surprise that about a third of our estate now is starting to demonstrate signs of age. We are working through that. There are some real positives in terms of we've just made a significant investment in upgrading the Wi-Fi, and that project has started. It started work in February. We have quite a lot of work going on to not think about how we replace all 1,900 virtual servers, but how we consolidate and converge those servers, and it falls directly in line with an absolutely vital EPR strategy that says we have to address these 900 plus different applications that we've got. So this is of concern because out-of-date servers does mean that we carry risk. We are mitigating much of that risk. We have monitoring in place. We have work to remediate. To give you an example, we had 300 Linux servers, which is a type of operating system. All of those were showing out of date. We have now switched off I think over 100 of those already, physically shut them down and removed them from our organisation because they're not in use. There's a high number of those that have now been updated. The versions of the software has been updated, so we have an active programme working through this, and we have an infrastructure remediation programme that is reported through to Change Portfolio Board to make sure that we are making this visible. So while there are clearly some challenges and our environment is starting to age, we do believe we've got some good controls in place and we're starting to work through this. There is a lot still to do. But we are continuing to move forwards, and the convergence is really the key to this application level and server and equipment convergence.
Thank you for very thorough updates. It's reassuring that in place that as well, we just continue to monitor rest with this. Thank you. Jude, you.
No, it's all right. I'll pick it up with Carmen at side.
Right, thank you very much. So can we receive and acknowledge the updated report? Audit and Risk Committee update. Tim, please.
Yeah, I'll be brief. I mean, one of the features I think of the Audit Committee's report here is some of the interconnectedness with what heard from other committees, which is good. So, for example, we had a deep dive at 13th of February looking at digital systems.
sustainability, which kind of allowed the non-executives to kind of test and hear about the controls and assurances with regard to that. Big piece, obviously, in the alert section is the range of limited assurance audits that we considered across the states, nasogastric tubes, never events, which have a structure of being referred out to other committees after our scrutiny. There was also discharge planning, which Jude was able to bring back, and which had been a previous limited piece, but was now brought into the wider actions that are taking place on discharge planning. So that gave assurance to the committee with regard to that. And equality, diversity and inclusion, an update on the progress with regard to that limited assurance. I think everything else is kind of self-explanatory in terms of our external, internal audit oversight. The only, it's kind of a minor one, but it's important that it's referred to the board. It's, as a committee, we approved an increase to the threshold at which gifts are to be declared from £25 to £50 in line with national guidance. So we gave that approval, but it needs to come formally to the board. So that's all I wanted to cover in that update.
Thank you, Luke. Very thorough and gives a good insight into what's happening within our audit processes. Can I just ask about the anti-fraud progress report? You mentioned 6 open queries. Would you actually say what they are? Have I missing page 4?
I can't recall the exact detail. I don't know, Craig, this is one that
we can certainly get an update on that, Chair.
Just like the gap, because I don't know if they are, so it just needs to be the detail, just to make sure we have that full.
Yeah.
Thank you. Thank you very much. Thank you, Tim. Very concise.
I'm happy to take an action to fall back on that, Chair.
Please do. Thank you. Right, so Louise. Okay.
Sorry.
Oh, sorry, I didn't see.
Just a point, sorry, Tim. Just picking up on the alerts in the audit. This overdue internal audit management action, that's the limited assurance audits. We talked earlier about the sort of operational risks which were overdue, that we all suggested about water. And when the 2 limited assurance audits were looked at in the performance committee, I think one of the things we challenged was the sort of practicality of the timescales, deliverability of some of the actions that were being taken. So I just wonder whether there's a general theme about making sure that the actions that we agree to are A, doable in the timescales, but B, are reasonable and rational in the context of everything else that we've been talking about in terms of the financial position and the operational position. I think sometimes we have an opportunity, we sometimes have a tendency to respond in a purist way and try and overreach ourselves. Don't manage to do it. An example, Rafiq, is the consent audit where we're dealing with overdue actions, but actually the thing we said we'd do is put in a super duper computer system, which was never going to work. You know, it's going to take years to do, but we committed ourselves to that. So I just wonder whether there's something about calibrating the way that we respond to these things. Not to be under ambitious, but to not set ourselves targets which we're never going to meet.
I think it is, there's still an issue there. You're right to flag it, Chris, but we've got a very much improved position. I think a year or so ago, we had a build up and the audit committee has kind of policed that. The execs have kind of been challenging upstream a bit. So we're not seeing so much coming through. And I think we did have a good challenge discussion with Heather, who kind of gave us good evidence of how she had kind of kicked the tires on the actions. So I think it's one we need to be permanently attentive to, but it's a better position than it was.
Definitely. That's it, we've had 12 months ago. I still feel there's a sort of, let's make sure our actions are.
Yeah, I think there might have been a period where
individuals were committing to things, and the exec directors probably hadn't quite signed that off.
Yeah.
And that gap has been closed now. But
Yeah.
but we do need to be alert to other people's optimism. If there's
Thank you for that one, Chris, and thank you for responding. And we've noted that. But we come back into.
Yeah, no, it was just to say, I think Tim's point's right. We've had the conversation about working challenge on the action plans before they arrive at an audit committee or a Q&P. We just have to be mindful of two things, I think, and it is about risk appetite. One is there are some things that get driven externally. So discharge audit, for example, we have to have discharge ready dates in and be reporting them nationally. So that puts the pressure on us. It puts the pressure on Lorna's team to be able to pull the data out of the systems. It's not a negotiable. So we probably love a bit more time, but we haven't got it. So there's sometimes external factors that are at play. But equally, I think we have to think about what's the risks that are associated with the limited assurance reports that we've got. And I think there's a balance, isn't there, in between a call to action in being able to manage a risk that clearly is, you know, have we got a risk that's outlined as a result of a limited assurance audit report? Yes or no? How high is that risk? And therefore, actually, how much does that need to drive the timeliness of the action? But I think it's thinking about it in that context.
It puts it much more elegant.
There's also something about not creating a culture of limited assurance without having the context explaining why. So the explanation is crucial within that narrative. So I'm going to leave, as we said before during the conversation, that we will continue to improve our governance processes in the short term. So thank you, colleagues. May I conclude this item now and move on to the next one? Thank you very much. And that is change portfolio board. We're going to have people first by Owen and then by Louise. Welcome.
Thank you. So I will cover off 16.1A, 16.1B, if that's okay. And I think just speaking to Chris's point and just linking into this conversation, I think underlying what I think I was hearing from Chris was the alignment of our capacity to do some of this with the commitment to actions and so on and so forth. And if you remember, one of the themes that we've had under the portfolio board discussions has been around the capacity to do. I still think that remains an unanswered question that we still need to work through. But in terms of the two papers, in relation to the January piece, there were probably 6 areas where we were alerting on things like clinical leadership model, status remaining red at that point in time, application excellence linked to unmet financial benefits and delayed milestones, data excellence, again financial benefits and programme plan sort of coherence, urgent emergency care, again sort of due to the extension and sort of had the lack of clarity around some of that. And then also in terms of medical workforce, again, a programme and delayed milestones, and then a target operating model that can, at some point, it's probably going to come off there and is going to be rejuvenated as target operating model version 2 or 3 at some point in time. So we probably need to think about when that gets closed. The reason why I just reflected on those is that they kind of repeat through then to the February paper. The distinction though that I will make is that in the February paper, which is 16.1B, there is progress identified around the clinical leadership model. And I think that's quite an important point just to reference, because often when we're looking at these papers and the progress that's been made, they can feel rather static, particularly when you're going from a month-to-month basis, which is, I think, a comment made earlier about another set of analysis that we've got. I think Tim made it earlier. The difference that you would expect to see month on month can be quite challenging, particularly when you're doing complex pieces of work. But nonetheless, if you look at the February piece, there is quite a kind of a bit of movement, important movement for me, in terms of the clinically led leadership model state improved to amber and reflecting on track activities. So I think that's important. And I think several of us, for example, have kind of lived some of the reality of the clinically led model recently, as we've been doing some of the delivery group assurance pieces. So that does feel like it's moving forward, and also talk about the validity of the work that Louise's team does in terms of really helping us understand where we're at in terms of programmes and what are the opportunities for moving forward. I think the final point I'll make, because I am conscious of time, is that when we talk about some of the things that remain red and that will be alerted, I think if Joe Gibson was here, the point he would be making is that typically these are the programmes that straddle across quite a lot of other areas and other activities. There are things where perhaps there's less about trying to get marginal gains as what you might get in a, say, care or work programme or improvement work programme. So you have lots of marginal gains that can feed into overall progress. These are the ones that are typically spanning boundaries, which makes it challenging for them to be worked through. But nonetheless, we've got the governance that's kind of underpinning us and helping us see what we need to improve to get some of this moving forward. So I'll talk that. There's several deep dives we talked. So, for example, in the January paper, did things on communication. There's several deep dives that are covered in the February paper. I won't go into detail on those. I'm working on the assumption that people have read the papers and happy to take any questions without overshadowing the assurance piece that Louise will give.
I'll make sure that Michelle. Are there any questions or comments for Owen? Papers very thorough. I mean, you mentioned scope creep and capacity and attendance. Do you have any good comments?
Yeah, I really don't have a magic bullet question response to that actually, because you know, we're certainly not wanting for work. Let's put it that way. And we're in a scenario where if you just look at executive, you know, as a result of the target operating model, we've reduced the executive capacity that we've got. Those are the realities of where we're at. And I suspect when you look at the indicative fiscal position that Craig was sharing with us and what that ask will be, I would suggest when we then start looking at things like high risk options, there's one thing looking at them, there'll be another thing then about enacting them, and again the capacity requirements on that will be significant. So, you know, it might be, Chair, that this is one where we have to take this into a board workshop conversation, maybe get facilitated help to have a conversation around it, because I haven't got a answer that I can pull out of my pocket on this one.
But it's one that we do need to have further thinking and consideration of. So your suggestion is a good one, I think, particularly that. There are no more questions for Owen. Can I move to Louise with the assurance report?
Thank you. So I'll introduce the portfolio assurance report that's under item 16.2. So in terms of the format of the report itself, no changes this month. We've continued with the use of the movement arrows on the dashboard slide. That's 14 out of 45 in the slide pack. And then in terms of the assurance position at a portfolio level, so again, as usual, slide 1345 shows the graphs with the kind of trend of overall governance and delivery assurance ratings. The total number of programmes in the portfolio this month is 16, and we're assuring 13 of those. From a governance perspective, we've got the same number of green ride ratings as last month, so that's 6, and those programmes being maternity, med management, procurement, statement facility, digital infrastructure remediation, and also the same number of red ride ratings, so that's 2, urgent emergency care and medical workforce. And then from a delivery perspective, again, the same number of green ride ratings, so that's 5, maternity, procurement, statement facilities, digital infrastructure remediation, but a decrease, as Owen mentioned, in red ride ratings from 6 to 5. So the red rated programs being outpatients excellence, theatres excellence, urgent emergency care excellence, medical workforce, and the target operating model, and the movement being the clinical leadership model, which moved from red to amber this month. And as Owen said, you know, that's reflecting the on-track status of the activities presented in the programme plan, which was developed this month. Any programmes with red RIDE rated status are highlighted in the Matters to Alert section in the AAA reports. And just one more thing to reference. So for the programmes in scope, because of their contribution to the financial sustainability plan, so on the scope slide, which is slide 6 of 45, it's any of the programmes that are coloured in a green box. Assurance, particularly around delivery of benefits, this month and previous months, is focused primarily on the 24-25 financial year. The assurance reviews that we're carrying out this month will start looking ahead at the plans for 25-26, and obviously as we move into April, we'll be just around 25-26 going forward. Board there to allow any discussion.
Yeah, that's really helpful. Thank you for that. Are there any comments or questions? Ollie? So really good report. You know, as you say, the movement that we see is actually how it has been contextualised in the past. That it's great to see that the movement to, and that's a tough one. So many people has gone into making sure that happens. But again, try to continue improving and sure that cause change according to plan. But we understand their focus and your attention where there's less assurance, you're able to explain why and what we're doing to address those gaps. So colleagues, if there are no more questions, we can accept. Oh, is that right? So yeah, we just came up.
Yeah, just one the suggestion around the capacity conversation, and maybe that's a part of the workshop.
Yeah, please. Thank you very much. Thank you, Louise. So we move on then to agenda item 17, report from the charitable advocacy. Jeff.
Thank you. This is the last year of the 3-year strategy for local care. So the committee received and discussed first draft of revised strategy for local care. That work has had input from stakeholders across the trust and externally from other trusts. One issue that we debated at committee was a desire to push more funding into local communities, involving local community groups, invite them to be in conjunction with clinical teams in the trust, and thereby building partnerships as well as having impact on population health. The debate was measuring that against, weighing it against the expectations of people who are donating funding. You'll see their funding going to schemes entirely within the hospital. So we're going to continue the debate on that. It will, of course, come back as a part of our strategy with the board. We'd welcome comments from executive colleagues in the meantime on that key question. This new strategy will also improve the process by simplifying the decision-making process and the application process. And the new strategy will also align in due course the governance of the charity with the local leadership model. Thereby get the greater ownership of local care within the clinical leadership alternative. Other issues dealt with by the committee beyond the strategy. We discussed moving from 2 companies managing our investment portfolio to 1, and through that getting stronger ethical considerations to how our reserves are used, including checking against companies who are exploiting their workforce. Finally, just mentioned earlier on in the BH report, a couple of examples of grants given. We've agreed to enter into a partnership with the Royal Cultural Society to improve the gardens at Old Hospital, which is really exciting, and also the funding for the clinical research function was included in principle, subject to details being resolved by executive colleagues. So happy to answer any questions on the chair.
Yeah, sure. Are there any questions or comments? Again, local care charity is one of those really important assets of the organisation that you need to speak louder to. I'd like to, through you, thank all of the staff within that team do tremendous work. And I really appreciate the point you made around where we have donations and where funding is given. But I think we just need to be a bit smarter. I think you're right. We need to be more considered about especially neighbourhood level and change and the opportunity there. It's just changing the criteria to support. So we're completely transparent about what we're doing. Noted all of the further strategic changes you're making and the lens to health and poverty prevention links into that wider, or the form of content being achieved. Are there any further points of comment, Colin? And thank you, Jeff, for your reports. Moving then to agenda item 18, that is for notings, Chair report of Council of Governors. Unless there are any questions? Thank you very much. The board of directors closed session information, agenda item 19, that is for noting. Any comments or questions? No. Agenda item 20, any other business? So not that I've noted or comment on this part, so I will move on to board reflection. And well, I think we made up time, so well done. But no, I just think it would be remiss of me not to ask Jane to give her reflections. Not then. Some of your bits. So,
Are we switched off? My reflections on today's meeting. On like in general, we should meeting and aspirations for us going forward. I think as a valued colleague and someone who's fantastic insight on that's a really big chance. So I think papers for today's meeting. I see step change, step improvement in board papers. We're not there yet. I've spoken to Chris this morning. I thought Chris's AAA reports are bringing a bit of a punch now, and I think we should endeavour to follow that approach. We won't always get it right, but I think that's certainly something we could follow. So Chris, thank you for that, because I think that's helpful to us all and really focuses certainly my thoughts as we're coming into board. So thank you for that. I'd love to see that, us move away, because we do drift sometimes with the AAAs to be almost summary minutes rather than what the AAA, the ethos, the proper AAA report. So I think that's super. I think our board assurance framework risks, as they apply to the matters that we've considered, need update, need to be reflective of position today. And I think we've got more to do with regards to utilising those risk growths through our board committees and ensuring the board remains absolutely abreast of where those risk profiles are set and how those risks are prioritised for the board and therefore leading the agenda. And Tim and I have spoken about the format of the BAF and how we make sure that Tim, I know, is thinking this through about how we make sure that it really is helpful to you all as board members. But yeah, I think a great, I'm so much admiration that you, because at one point I was whispering to you, we're 40 minutes behind on their paper stuff. So well done.
Yeah, well done everyone for enabling that to happen and for your contributions. But I would like to make one final point before I go to final closing, and that is to acknowledge that it's Craig's last board meeting in public, interim financial chief finance officer. Make sure you're chiefing many domains, aren't you? Just to extend our thanks on behalf of the board. I know you've heard it many times, but truly heartfelt thanks to you for the way in which you have not just managed the FSP, but guided us and being the absolute stewards of where we are within our finance governance, our finance performance, and our finance opportunity. You kind of tick all of those wonderful boxes. But you're not just an FDR, you're much more than that. The way that you grasp the detail of all of the other aspects of what we do in terms of care, appreciate it, and provide, just as Jane in her capacity, it's just tremendous. And I want to acknowledge you, as a chief finance officer, but also acknowledge you for your massive personal, candid, open, transparent skills and technique. And the way that you speak very, very well, doesn't he? On really challenging areas of focus. But it does it in such a effective way. You think I can't repeat that just because the intonation in your voice. So thank you for your years of service. We wish you all the best going forward, and hopefully that you continue to keep that focus with the organisation and what you're going to be doing in many years to come. So thank you. I can hear the Tommy's wrongly, but just a few more moments. Date and time of the meeting is Wednesday, 2nd of April. And of course, to move the resolution that the public meeting is now closed on the grounds of publicity and matters being reviewed would be prejudicial to public interest by reason of confidential nature of business. The press and the public are requested to leave at this point. Thank you to the colleagues at the back who stayed with us. Really nice. Yeah. Everyone, lunch break.